fat, and T3D tumor, there will be more than 15 mm of the extension into the mesorectal fat. Now, MRF, as you all know, is the mesorectal fascia, and which significantly alter the prognosis of the patient with rectal cancer. And mostly we will need the neoadjuvant treatment for that. In this case, you can see on the left lateral wall, this involvement of the mesorectal fascia with a large tumor mass. Few small lymph nodes are also there, which I will describe you later. So, very important T4 tumors. So T4 tumors, so there is a mass in the upper rectum. The peritoneum is in very close contact with the anterior rectal wall. So sometimes we can upstage the tumor that it's like a T4A tumor. But as you can see, this thin hypointense muscle layer, the signal of this black line is maintained. So it's a T2 tumor, not a T4A tumor. For T4A tumor, there should be loss of that hypointense line, and there should be invasion or obvious involvement of the peritoneum. Then only we should tell it as a T4A tumor. Otherwise, it's mostly T2 tumor in the upper rectum. And sometimes T4A tumor can be MRF positive also. At some level, there is involvement of the peritoneum, and at other side, there is positive involvement of the MRF. Like in this case, anteriorly, there is involvement of the peritoneum. You can see there is further extension of the tumor from the wall of the rectum, and posteriorly, there is involvement of the mesorectal fascia. And now the T4B tumor. T4B tumor invades the adjacent structures. Like in this case, there is involvement of the prostate anteriorly. There's clear-cut invasion of the prostate by the mass lesion. And one very important thing, if there is any involvement of any skeletal muscle or any nerve structures, vessel structure, then it stays upstates to T4B. Like in this case, there is involvement of the left levator ani muscle. So the staging will be T4B. We will discuss the many cases after this presentation. So you will see all the cases like this of all the stages. So EMVI, as madam said previously also, that says that there are more chances of the recurrence with decreased overall survival. Chances of metastasis also there, because there is direct invasion of the venous structures, and as you all know, the metastasis to distant body spreads from the blood supply. So how to identify the EMVI? EMVI, you will see there is vessels in the around the rectum. So there will be nodular thickening of these vascular structures. There will be nodular tubular thickened structures in the surrounding the rectum, with the tumor of the rectum is seen continuing with these vascular structures, and the signal of the tumor as well as that vascular structures is the same. So then there will be in EMVI, and if there is the signal of these vessels is more black than the tumor itself, there can be fibrosis or desmoplastic reaction also. So regional lymph nodes and non-regional lymph nodes. Regional lymph nodes include the lymph nodes which we remove in the TME, and also the obturator and internal iliac lymph nodes. And the non-regional lymph nodes are lymph nodes which are outside that regional lymph nodes are the non-regional. In case of inguinal lymph nodes in lower rectal CA, inguinal lymph nodes will be counted as regional lymph node, and in high or mid rectum, inguinal lymph node is distant metastasis. These obturator lymph nodes are sometimes called as lateral lymph node because they are lateral to the surgical margins, surgical TME. So we have to describe if any positive lateral lymph node is there, because they are very common site of recurrence and decrease the prognosis and overall survival of the patient. So mesorectal lymph nodes, the staging all you know, N0, N1, and N2. N0, no suspicious lymph node. N1 is 1 to 3 suspicious lymph nodes, and N2 is more than or equal to 4 suspicious lymph node. And we can't definitely say if the lymph node is metastatic or no. We can only tell you the suspicious lymph nodes. Lymph nodes are suspicious if they are above the 9 mm size, then they are definitely suspicious. And if they are between 5 to 9 mm with two malignant characteristic and less than 5 mm with three malignant characteristic, then they are suspicious. And what are these malignant characteristic? There are three malignant characteristic. One is the ill-defined, irregular, or indistinct margin of the lymph node. Other is the heterogeneous signal within the lymph node, and third one is the round lymph node. Round lymph node are very suspicious lymph nodes. I will show you all the examples of these lymph nodes. So in this case, you can see this lymph node. Most normally, the lymph nodes are either very small in size or they are ovoid in shape. But in this case, you can see the lymph node is round in shape. And in this case, there is mass in the rectum, and there is one lymph node which is showing irregular margins anteriorly. And in this case, the lymph node is showing heterogeneous signals. So these are three malignant characteristics of the lymph node. And this for lateral lymph node, suspicious lymph node are called when they are equal or more than 7 mm in diameter. So in this case, there is a large obturator lymph node on the left side. We have to describe this lymph node in our report so that either they can excise the tumor or they can include this lymph node into that neoadjuvant treatment radiotherapy. So low rectal cancer are in few things different from the mid and upper rectum tumors, because there are chances of the involvement of the anal sphincter as well as pelvic floor muscles. So this is the schematic diagram of the normal anal canal anatomy. This is the internal sphincter. This is the external sphincter. This is intersphincteric planes. So if there is involvement of the lower rectal tumor with only internal sphincter is involved, then there will be no change in the staging of the tumor. But if there is involvement of the external sphincter or the other pelvic floor muscles, the staging upstage to T4B. So this is the normal MRI anatomy of the anal canal. So this is the internal sphincter. This hyperintense line is the external sphincter, which continues superiorly as the levator ani muscles. So this, you can see this internal sphincter is black in structure, and this tumor is intermediate or somewhat white in signals. So this low rectal tumor is involving the internal sphincter on the left side at this level. So, but there will be no change in the staging of the tumor. The stage will remain the same. But now in this case, there is involvement of the external sphincter on the left side with involvement of internal sphincter as well as. So this will upstage to T4B. And this is another example of T4B stage. So there is involvement of the external sphincter. You can see this is the normal external sphincter with hypointense black line. And on the right side, there is no black line is seen. So there is involvement of the external sphincter. So, what is the criteria for treatment stratification? We divides the patient of CA rectum into low risk, intermediate risk, or high risk, and the treatment is given as per the risk stratification. So, in low risk, we use CT1 to N0 or T3A or B tumors with no nodal metastasis, no suspicious lymph node, and MRF should not be threatened or involved. We can directly go for a surgical excision of the tumor, which can be TME or local excision if we know that tumor is T1. But for to diagnose the tumor for to be T1, endorectal ultrasound is more important or more useful than the MRI for the diagnosis of T1 tumor. Then the intermediate risk tumors are T3C and D, N1 with 1 to 3 suspicious lymph nodes, but MRF should not be involved or threatened. We can use short course neoadjuvant radiotherapy only. As such, there is no use of chemotherapy or no requirement of the chemotherapy in these cases. And high risk tumors are T3C and D or T4 tumors with N2 and involvement of the MRF. then we will need long course neoadjuvant radiotherapy as well as chemotherapy. And after that, we will do a restaging MRI to see if there is any decrease in the size or stage of the disease. So restaging after new adjuvant treatment, most of the criteria are the same as in the primary stage, especially in T staging. But there is few changes in the MRF and the nodal staging. MRF, because there is fibrosis after the neoadjuvant chemoradiotherapy. So when the MRF is involved, if it is less than or equal to 1 mm distance between solid tumor remnant, it means there is very poor response to the neoadjuvant treatment, or there is major fibrotic involvement, that there is significant fibrosis is there, but that fibrosis is involving MRF, then we will took that as involved MRF. And MRF is free when there is distance between the tumor or fibrosis and MRF is more than 1 mm. And if only few fibrotic strands are involving the MRF, then also there are very low chances of involvement of the MRF. Similarly, in the nodal stage, there is only one criteria, that is the size of the tumor, size of the lymph node. If the lymph node is more than 5 mm, then it is suspicious. Previously, there are multiple classification of the suspicious lymph node, but after neoadjuvant treatment, if the lymph node is more than 5 mm, then it's suspicious lymph node. So, how to assess the response to neoadjuvant treatment? So, what is the complete response? Complete response, that there is almost complete disappearance of the tumor, then it is complete response. And or there is dense fibrosis but no tumor signal on T2W images. And how to identify that that is only fibrosis with no tumor remnant? In that, DWI is helpful, which will be hyper intense if there will be any tumor remnant, and in fibrosis there will be no restricted diffusion. And then good or partial or intermediate response is there is predominantly fibrosis with few foci of tumor signals, and these foci will be identified on the DWI images with small foci of diffusion restrictions within the fibrosis. And poor response after the treatment is this predominant tumor signal with minimal or no fibrosis, and DWI will tell you that it's a tumor. There is no response. So I will show you few examples of the post neoadjuvant treatment restaging MRI. In this case, you can see there is a solid mass in the rectal wall along its left rectal wall. And on T2W images, on this image, this it's in the range of gray signal, not black, not white. And now it's mostly black signal, but on diffusion there is hyper intense signals, and ADC is very important. ADC only tell you if there is restricted diffusion or not. Otherwise, sometimes there is T2 shine through, and which is artifactually like an artifacts in the DWI images. So there is some residual tissue, so it will be a good response or intermediate response to the CRT. Now another example, there is a very bulky tumor around the left lateral wall, and on the post CRT T2W images, it turned into the black structure, and on DWI images, there is no hyperintensity and no restricted diffusion. Another example, this small tumor into the left lateral wall. Post CRT shows hyperintense fibrotic signal, but DWI images are showing hyperintense signal. So it's a partial response to the neoadjuvant treatment. Similarly, in this case, MRF is involved, but post-CRT, the distance of the tumor from the MRF is increased. So this is free MRF in the restaging. Similarly, in the lymph node, these are the primary lymph nodes after neoadjuvant treatment. One tiny lymph node is seen, which is significantly less than 5 mm. So it's a good response. So what are the take-home points? Most important, your images should be perpendicular Axial images should be perpendicular to the tumor itself. For low tumors, we have to describe the relationship of the tumor to the pelvic floor muscles and the anal sphincter. We should have the knowledge of peritoneum, because in the lower one third there is no peritoneum around the rectum, and in the mid and upper rectum also there is only peritoneum is only anterior to the rectum. Identify the key parameters, that is low rectal cancer, T stage, depth of invasion, CRM status, EMVI, and tumor deposits. As I already said, MRI is poor at determining where the lymph nodes are definitely involved or not. We can say that these lymph nodes are suspicious. And most important, in case of restaging, endoscopy review of the tumor site is essential to confirm complete response. If there is any tumor on the endoscopy, it means there is partial response or no response, and MRI is not that good in these things. Thank you. I can take few questions if any have any question. Yeah.
Endorectal ultrasound and endoscopic ultrasound. This modality will
Definitely endorectal ultrasound are more helpful than the perineal ultrasound, and it will be helpful if they how much is the involvement, but it's more important in the mid and upper rectum than the lower rectum, because you can see the involvement of the internal sphincter very well.
The normal you told that 5 to 8 millimeters, that is the cutoff. But the lateral concept only 7 millimeters. That is the criteria. Yeah. That's why 8 and 8 and 9. That is outside the
Criteria is different. Yeah.
Also, I think, Dr. Narottam, what I find while we are looking at the images, that upper rectum tends to be, more inferior on imaging than usual anatomy.
Yeah.
Because it tends to drop down, because of the loose mesorectum.
Yeah.
And when during the surgery you pull the rectum up, it comes at the sacral promontory.
Yes.
But whenever you see the MRI imaging, it is usually between S4, S3. So sometimes while reporting, there can be a mistake. When you report upper rectum, it may be middle rectum and vice versa.
Yeah, it's a very common mistake actually, because in the colonoscopy also the distance is very different than in the MRI
Most
imaging.
of the times,
Yeah.
though gastroenterologists don't agree with that.
Yeah.
But I think in around more than 50% of times we find that correlation with colonoscopy is not good.
So that is why we take the sigmoid takeoff and not the sacral promontory. So we just take wherever it becomes horizontal, that's what we do.
That's a very important point to remember for the audience.
So thank you, everyone.
A very good morning to everyone. So now that we've gone through most of the anatomy and reporting key points, so we'll just probably try and get a sense of how to apply these in a real world scenario. So I'm going to go through 4 cases with everybody and of different findings. Every case is going to be having a couple of key points from a reporting standpoint, and also the fact that I'll try and keep it as easy and digestible for everybody. We won't go into too many intricate details, but at least the broad overview of what to expect when you're looking at a case of CA rectum. Can I have the screen, please? Okay. So as has already been discussed, so our most important sequence when evaluating for rectal cancer is the sagittal T2. Again, as ma'am has clearly said, the non-FATSAT images to enable a very good differentiation between the rectal wall and the surrounding mesorectal fat. So the first key point, so this is a sagittal T2 image in an elderly patient who obviously the referring point is always a known case of rectal cancer, biopsy proven, and MR is done for staging purposes. Very rarely is it done to evaluate a rectal growth. It is mostly a biopsy proven growth. So the first thing that we need to know is that we're doing a staging scan. Now on sagittal T2 images, the most important point is to assess what is the point of the lower margin margin of the tumor and the segment of the rectum that the tumor is involving. So now a good way for that would be to look at the normal wall. So this is our anal verge, and from the anal verge, if you look closely, we have a very nice and thin rectal wall. So can everybody see the arrow on the screen? So yeah, so this is the rectal wall, and you can see that there is a transition now. This is a segment of the rectum that is very obviously thickened. You don't need to be a radiologist to appreciate the thickening of the rectum in this case. So you can see that there is a definite thickening of the rectum in this region. So when you start evaluating this lesion, so what I normally do is I just scroll through the image to get a sense of the upper and lower margins of the tumor. So we can very clearly see that this is the point where our thickening of the rectum kind of disappears into a normal fecal loaded upper rectum. So what do we do first? Now we'll probably try and measure the lower margin of the tumor from the anal verge. So again, this is not an actual workstation that we're using. This is a software, so there might be a little bit of discrepancy, but this is just to give you a broad idea. Now, if you look at this, now this is the lower margin. So this is approximately 6.1 centimeters from the anal verge. Now, 6.1 centimeters from the anal verge means that this is predominantly a mid-rectal lesion. So a mid-rectal lesion. Now, the next thing that as radiologists we have to be careful to report is the total extent or length of the involved segment. So now that we have a overview of where the lower margin of the lesion is, now we'll try and measure the lesion in its entirety. So normally, because these lesions are mostly, they have undulating margins, there's a little waviness of the rectal contour as well. It's not possible to draw a straight line and measure the entire lesion in one go. So obviously on our workstations, we have like multiple windows open at the same time, so we can cross-reference with that. But what we would do here is that we'll probably try and take two vertical lines and just add the distance. So this is approximately 7 centimeters. So we have a lesion which is 6 centimeters from the anal verge, the lower margin, and involving a length of approximately 7 centimeters. So predominantly a mid-rectal tumor extending into the upper rectum. And as has been pointed out, the point of inflection between the sigmoid and the upper rectum is the sigmoid. Yeah, please tell me. Absolutely, absolutely. Let's make this interactive.
I think, madam. But start
Yes.
measuring.
Yes. Yeah. Okay. So again, this is a little bit of a approximation, but grossly we get to see this differentiation. So you can see this thickened segment here. Can you make that out? So this is the anal verge. So this T2 hypointense muscular thickening that you see around that region. By T2 hypointense, I mean whatever is the dark area, you know. This, you see this hypointense segment here where the cursor is. So this is the anal verge. And this corresponds to the point at which we first start seeing the muscular fibers. So that is the anal verge here. Because distal to that, if you look closely, so there's definitely a little bit of, there's a phenomena in MR and radiological imaging, which is called partial volume averaging or a volume averaging artifact. So all this hypointense signal that you see here, that is basically the interface between the gluteal folds. So you can ignore that and just look at little lateral. And here you see a very clear demarcation. So this is the anal verge. So again, we might be a couple of millimeters here and there off, but this is just to get a broad sense of
Your tip
what
there would be to go a bit lateral.
What?
And would be to go a bit lateral.
I think you can do that, but generally what we have for reference on our monitors is a corneal, a sagittal, and an axial in tandem. So we can cross-reference that. So the marker we place on corneal. So I'll just show you on the corneal image as well. So this is a corneal scan, right? So in this case, probably it's a little better appreciated if you can see. So this is the distal end of the anal canal and this is the anal verge. So what normally we do on our systems would be place a point here, cross-reference it with the sagittal. In cases of confusion, this is not a big point for confusion anyways. Okay. So going back to our sagittal images, just a second. So now that we've established where the tumor is, our next point is to assess. Another thing that we need to cross-reference and check is whether the planes that we've acquired for axial images are okay or not. Because our next point would be to assess the rectal wall. Now, so what we generally we want. So you can see the cross reference, the green lines that are on the sagittal images that are planning our axials. And in the upper part of this lesion, you can see that these lines are not very perpendicular to what we would expect in nature. So here you would see that they're little obliques. So it's a good idea to have two axial sets of images. So you can have an axial to that particular. So if you have two segments of rectal involvement, you can plan axials for separate segments separately. That is a common practice that can be done in probably in large tumors that are spanning more than one rectal segment. So again, so we'll come back to the images that have been planned according. So these are more or less appropriately planned axials. Now I'll zoom the axial images. And now as we scroll down, the most important thing for us is to evaluate the rectal wall. So this T2 hypointense wall. Now as we go cranially, now this is the point at which we see the thickening best. Now, as has been discussed by Dr. Narottam, so at times along the margin of the wall, you see these thin strands that might project from the rectal lumen, from the rectal wall. And there is a tendency to get confused between T2 and T3A lesions at times, because a lot of T3A or T2 lesions may at times have these thin strands which mimic desmoplastic reaction. So more often than not, with a little bit of experience, obviously, you tend to differentiate between them better, but very thin segments of stranding, very localized and not really similar to the tumor signal intensity, we would tend to call that desmoplastic reaction. So in this case, this was what we called it. We called it a desmoplastic reaction. Now, and if you look at the entirety of the tumor, the wall, the outline or the serosal part of the wall is very nicely seen. We do not see any definite breach. If anybody has any areas of concern in this particular image, you can tell me, please. Okay. So again, so yes, so these are very linear strands branching, very prominent. So a little bit of increased perirectal vascularity. Look at the dark signal of the tumor and look at the signal intensity of these thin strands. It's clearly very different. So we can call this increased perirectal vascularity, or we can call it desmoplastic reaction. It doesn't really make a difference as long as it is not T3A or B that you're missing. Yes, sir. Sir, again, these are probably very thin vessels which are seen in the perirectal region. So another point is that whenever you have such a confusion, coronals can be a real lifesaver at these points. So you put a matching coronal section. Now look at the lesion on coronals and you'll see the difference between the axials and coronals. So this is our coronal image. And all those areas of confusion that we had in terms of the linear strands and all, they're not very well appreciated on coronals. You can see very nice outlines of the rectal wall in this case. So this, we call this a T2 lesion. Operatively, it was proved to be a T2 lesion. And the next thing when it comes to the role of MR is evaluating for nodal status. So again, very nicely covered earlier, but how do these nodes actually look when you're scrolling through images? So again, another anatomical point that I would like to point out is we've seen very good images of mesorectal fascia, but how does that look when you're scrolling through images? So this thin line that you see along the margin of the rectum, mostly covering the lower and mid rectum, deficient anteriorly in the mid rectum and along the superior rectum. So this thin margin that you see along the margins of the rectum, this thin line, this is the mesorectal fascia. So in one of the next cases that I'll show you, we'll probably evaluate the relation of that with the lesion itself. Now, confined to the mesorectal fascia are vessels and nodes. Now let's look at some of the lymph nodes that are there in the mesorectal fascia. One of the nodes is this. So we're looking at size. The first criteria that we're evaluating is size. And if we go through this particular scan, there's no obvious enlarged lymph node that we see is more than 9 mm. Okay, so one thing is for sure that whatever nodes we have, now we're looking for malignant characteristics in those. We don't have a node that is definitely more than 9 mm. More than 9 mm, we definitely called it an involved node, no matter what the histopathology later corrects us or not, but that is what the accepted norm is. So now coming to the next criteria, now let's measure this node. Okay. So if the node is between 5 and 9 mm, so we're looking for 2 malignant characteristics. And if the node is less than 5 mm or equal to 5 mm, we're looking for 3. So what are the malignant characteristics? We have a round shape, we have irregular margins, and we have heterogeneous signal. So that's what we were looking for. Now, if you zoom this, so this is approximately a node which is 5.7 mm. Again, a little bit of discrepancy can be there in measuring because we are not using proper tools. But again, in a 5.7 node, what we would expect is two malignant criteria to call it positive. And what are the two malignant criteria? So this is definitely not a round node if you look at it. It's slightly ovoid. One criteria is missed. It's not that heterogeneous, and the margins are okay. Heterogeneity is fairly subjective for such small lesions, even if we tend to call it a little heterogeneous in the sense that there's a little bit of high signal, other low signal, but we definitely do not have an irregular margin. So even if the one malignant criteria is met, we can still not call it a malignant node. So it practically does not change our staging. So
Dhruv,
similar, yeah.
sorry. If you have indistinct margins, irregular margins, then how do you make out the shape, whether it is ovoid or round?
Yes, sir.
Very
So,
difficult.
yes, sir. It is.
Then you cannot just.
Sir, from what we've seen in cases is that generally when a node has irregular margins, the shape, obviously the shape criteria might not be met. But when we have a slightly larger node, say between 5 and 9 mm, tending towards 9 mm, then we're fairly certain that this is a more rounded node, even if it has irregular margins. So I'll show you an example. I think I have one in which we might be able to establish.
It is less than 5 mm,
Yeah.
and their margins are irregular.
Agreed,
and
sir.
heterogeneous, then we can,
Yes, sir.
safe to assume that this is involved node.
We can call it involved, sir. But again, coming from a little bit of experience, we can say for sure that at times, generally, these nodal criteria, even when met very clearly, do not reflect in the pathology reports. So I would tend to take them with a grain of salt. But again, with reporting, we're only looking for very conclusive criteria. So whenever we don't find any conclusive criteria, we tend to underreport that rather than overreport them.
The problem is after when we have a single node involved, and then we don't know what to call it, because then we expose it's a T2 disease and only single.
Absolutely, ma'am. Call it N1 or N0. Yeah.
So are there any special measures which you take for the reporting of nodes, like giving some dye?
Contrast?
No.
Contrast
It doesn't
has
help.
not. Sir, contrast in rectal imaging overall is losing a lot of favor. There's absolutely no role. Even in post chemo cases, post radiotherapy cases, contrast is not indicated per se. There might be some
reports that some special dyes which sort of enlighten nodes more than the soft tissue, like they're not available.
So this was reported eventually as a T2 N0 disease, which was later proven on pathology. Any doubts up to this point, please? Because we'll proceed for, yeah, tell me.
Not specifically for rectal cancer, especially in like a breast. We would describe a node that there is a loss of a fatty hilum. So I assume that a node would generally be heterogeneous. There would be fat in between and outside. How do you differentiate that?
See, these nodes that we encounter in the mesorectal fascia, they're very small. So those fatty hilum criteria that we have, they're very well established on ultrasound, and they're established for probably larger nodes. On MR rectum per se, loss of fatty hilum is not a criteria for evaluating it. They can lead to a little bit of heterogeneity in signal. That's why I mentioned that in this case, in nodes less than 5 mm, that's a very, very subjective call, and in most cases does not influence our upstaging. And as ma'am has rightly said, this is something that we would only be concerned about when we have a solitary node with plus or minus involvement. That is something. But again, less than 5 mm, that would not be a parameter that we would be concerned about. In mesorectal fascia, the most important criteria is definitely the shape and outline and size. Signal intensity, in my practice, I personally feel that we should be a little wary about signal intensity. There's a tendency to report almost every node as heterogeneous. If you look too closely, you'll find heterogeneity in almost all nodes. So we'll just be a little wary with that, and we'll probably emphasize more on the other parameters. Let's see, we have a few more cases if we can find a better looking node that can solve it.
Also for fatty hilum, we have T1W images and which that show the fat in the lymph nodes.
Yeah. So now coming to the next case again. So this is a patient who's presented with a rectal lesion, and we'll start with this probably might not be a very clear image. We do encounter this issue in some patients. Not every patient is very comfortable in the MR scanner. Some patients, because of their other comorbid conditions, might have a lot of breathing happening, and we might have a little blurriness of images. So we do try and rectify that with giving antiperistaltic agents and stuff, but at times the images might not be ideal. And as radiologists, I think this is one of the skills that we need to develop also, to report suboptimal images at times wherever possible. So now coming to the next case, in this case, I've taken the liberty of already putting in some measurements for sake of saving time. Again, in this case, what we're seeing is we'll start with the sagittal T2 weighted images. And on sagittal images, we can see, again, we'll try and differentiate the demarcation between a normal rectal wall and the lesion. Now, in this case, let's not look at the posterior aspect and look at the anterior aspect. Now, look at this thin, smooth wall, and then see this transition to a relatively thickened segment of the rectum. Now, again, as I told you earlier, I just scroll through these images and try and distinguish or demarcate the upper wall. Now, if you look closely, in this case, we're not very confident about where the upper margin of the lesion is on T2 weighted images. There's obviously this abundant thickening here, which is definitely disease, but it gradually tapers off cranially. There's not a very sharp demarcation as you would see. So in this case, in such cases, diffusion imaging is a lifesaver because you can cross-reference that with diffusion weighted images, and diffusion, more often than not, you'll have, say for mucinous tumors, most of these non-mucinous adenocarcinomas. Now this is on your right-hand side. Now you see this image. So that's a diffusion weighted image. It's very dark, so I'll just scroll through it. So this is the rectal lumen, okay? And as you come, now you see this brighter segment that you have. It's an asymmetric brighter segment. You have a thin wall here, and this is slightly brighter. In an ideal world, I would have something called an ADC map to confirm that this is restricted diffusion, but this is just for the sake of making it simplified. We'll just browse through it. So diffusion weighted imaging also has a role in at least delineating the margins. A lot of time it helps in differentiating EMVI, which is extramural venous invasion, and all of those things. So it can have a role in those cases. But in this case, so the cranial margin of the lesion is approximately at this level. And so this is the entire length of the tumor. Now, again, after once you've established that this tumor is approximately 4 centimeters from the anal verge, now what happens is anything that is 4 centimeters from the anal verge, we'll classify it as a low rectal lesion. And so the superior extent of the lesion is extending into the mid rectum. So we have a mid and low rectal lesion. Now, in this case, again, the next important step is to make sure that the images that we have are orthogonal. Okay, so these are the axial images, and these were orthogonal images. I think the cross-reference points are not coming very well, but I'll just zoom on the axial images now. Now look at this lesion. And if you remember the previous lesion, there were those very thin spiculated strands at places, not along, very convincingly along the entire circumference of the tumor. And definitely that was a gray area. But in this case, if you look closely at the rectal margin, along the anterior aspect and along the right lateral aspect, and look at this margin. So you see these very obvious spiculations which are protruding into the mesorectal fat. And these have a signal which is more or less comparable to that of the lesion itself. So now we're pretty sure that the lesion has breached the muscularis. It's gone into the perirectal fat. And now our next reporting point as radiologists is T3A, B, or C. Now A is practically less than 1 mm. So we're very confident that this is more than 1 mm. This is not a gray area. We don't have a dilemma as to whether this is there or not. Now, if we measure it, although again, with all measurements, I'm pointing it out that these might not be very accurate on these systems. But again, if we just probably measure a segment of this, so we're pretty confident that this is more than 1 mm. Okay, if you look at this, I've zoomed this a little. So this particular projection that is jutting out from the left anterolateral aspect of the rectum. So this is approximately 3 mm. So and this is definitely not more than 5 mm in any of the sections. So when you look at this, now we are a little more confident that this is probably 3B or C. Now, when it comes to the next point in T3 lesions, now we have to assess its relationship to the mesorectal fascia. Now, if you look closely, this T2 hypointense line, it has a slightly ill-defined margin, but you can make out that this is the mesorectal fascia, this margin of the rectum. Now, as we proceed caudally, and this is where we have the lesion, we know that this is the bulk of the lesion is along the anterior and left lateral margins. The right posterolateral margin is relatively devoid of the lesion. So this is more than 1 mm from the mesorectal fascia at least. So definitely in this case, we would not be concerned about something like a CRM of a mesorectal fascia involvement. Now, the next point in this case is, and what is more interesting is, I think, the nodal status. So we're calling this a T3B lesion. with no involvement of the mesorectal fascia. And now let's have a look at the lymph nodes. So generally for nodal involvement, it's a good practice to have some wide FOV, field of view images, which probably cover a little bit of your iliac vessels and the aortic bifurcation as well, because those are areas where you might be surprised by a metastatic node at times. So in this case, we are just looking at the zoomed in or short FOV views, and you don't see any definite striking enlarged lymph node. If anybody can point out any lymph node, please let me know. Can you see any lymph node in the mesorectal fascia? No. But if you look closely enough, so there is an enlarged lobulated node which is seen outside the mesorectal fascia on the left side. Now let's measure this. Yeah, so this is your point. So this is around 8 mm. Yeah? And so this was, so the 7 mm criteria, I think, gets a little fulfilled for this node. This is definitely more than 7 mm. But even if that criteria we keep aside and just look at the plain morphology of this node, you can see that this is not a very round or ovoid node. It has slightly lobulated margins. It is extremely T2 hypointense. Although it has homogeneous signal, but again, it is a very dark node, not normally. So look at some of the other lymph nodes, which are smaller. Now look at this lymph node. So we can be fairly confident this is a non-involved node. It does not have a very round shape. It does not have irregular margins, and the size is definitely less than 5 mm. So in this case, we have this enlarged left lateral lymph node, which was found out to be an involved lymph node in this case. Again, just browsing through some of the coronal cuts in this case. So you will get a sense of how this lesion looks. And so again, so you can see the low and mid rectal morphology of the tumor on this one. But again, coronals are not actually very representative in all cases. We just mostly from a reporting standpoint, we use them to assess the lateral walls of the lesion. Most of these lesions that are along the anterior and posterior margins, they're not very well assessed on coronals. And I'm not covering metastatic disease because nodal metastasis we've already discussed. And if we have a case, we'll definitely go through that. But the other structures that you need to look for closely are the remaining pelvic viscera, the peritoneal reflections, the remaining solid organs. Since they're not involved in these cases, so I don't think we need to just go through them. But I would, as a radiologist, I would just look at the relationship of the lesion to the urinary bladder, some of the pelvic organs, and also look for any osseous lesions, just to, be more thorough and not miss out on any other lesions. Any queries in this case?
I often wonder that do we have any kind of measurement to measure the thickness of the mesorectal fat? Why I'm asking that is, suppose a patient who is bulky has a very thick mesorectum, and there maybe if you say that mesorectal fat involvement is more than 5 millimeter, does it have the same significance as compared to a person who has a mesorectal fat which is very thin?
So mesorectal fat, I think I'm not very well versed with whether there's any standard.
You understand what I'm trying to say?
Yeah, I get it. But if we're just looking from a case to case basis, I think, sir, we can measure the mesorectal fat.
Yeah, but then if there is any criteria where you say that if the mesorectal fat is say 5 centimeter, I'm just giving a
Yes,
figure.
absolutely.
In that, more than 5 millimeter involvement may not have that much significance as compared to when mesorectal fat is only 2.5 centimeter.
I don't think, sir. I'm not aware whether the.
Your question is very, very valid. It is like depending.
Makes common sense.
Yeah.
Hmm.
But what we are basically now looking at is just involvement of the CRM for you. But that is your plane of dissection. So I think that is what is most important. Yeah.
So basically, we are calculating in a reverse way. We are saying if the tumor is not extending beyond 2 millimeter from the mesorectal fascia, it has same characteristic whether it is 5 centimeter or 2.5 centimeter.
But
So
I think what you're saying really has a point. I think they could do some work on this. Yeah.
We should do probably start some study.
So I think, sir, what described the MR rectal cancer 2.0 and 3.0 more recently, what they're focusing is, I think, as ma'am said, is on the plane of dissection. So whether the patient is operable from that standpoint or not. Now we'll come to the next case. So again, now, as everybody is fairly conversant now, identify the lesion, the lower margin of the lesion from the anal verge. In this case, it's approximately 10 plus centimeters. Definitely an upper rectal lesion. Now, in this case, if you look at the lesion, it's very sharply demarcated. We don't have a lot of confusion as to where the lesion starts from and ends from. So this is like a radiologist's delight. You don't have to really rack your brains around it. But in this case, what the interesting part is that when you have to look at a couple of things more closely. Now I'll just again with sagittals, we'll see if we've planned this properly, because that is most important. And in this case, the point I'm trying to make is that if you look at the axial images, now this is a case in which we have a histopathologically proven extramural venous invasion. And look at this particular section in this cut. Okay, you have this, yeah, you have a very thick wall, a thickened tubular structure, which is jutting out from the left lateral wall of the rectum at the site of the tumor. And this is not a very textbook example of EMVI, because again, you might just be tempted to call it, a more advanced T3B, T3C kind of a disease. But look at the margin. There's no speculation. It's almost as if it's very well contained within a structure. And also it has a tubular, very sharply demarcated bulge along it. So this was an EMVI, which was proven histopathologically. Also, in this case, if you scroll cranially, now look at this particular structure here. Okay, so this is in the probably, and if you look at the sagittals also, I think we'll be able to see it pretty well. So here is this. Now this is an enlarged lymph node, and this is a relatively higher presacral region nodal lesion. Now in this case, you really don't have any doubts. Although if you look at it, so the variation is such, why size is a very important criteria. If you look at the margins of the node, there's no irregularity. If you look at the signal intensity, again, heterogeneity is a very subjective term, but it looks relatively homogeneous, some high signal areas. But look at the margin of the lesion. Very nice sharp margin. So there's obviously no one factor which we can say is more deciding than the other. That's why they've kept 3 malignant criteria. In this case, obviously a node which is, even if we don't measure it, even with visual oversight, you can say that this is an involved node. Again, this was a T3B lesion with EMVS. So in this case, we have this tumor infiltrating into the perineural or perivascular structures. And in this case, actually, we have a few other lymph nodes. Now, if you look at this particular lymph node, can you see it on the screen? So this is around 6.3 mm. I've measured it. And the morphology of the node is such that if you look, this is relatively easier to call a heterogeneous lymph node. So there's an anterior part which is relatively bright. There's a hypointense part posteriorly. Not very irregular margins, agreed, and not a very typically rounded shape, but you would again be pretty sure that this is not an ovoid lymph node. So we are fairly confident. So when we reported this case, we actually pointed out these 2 lymph nodes as involved, and pathology always has some surprises in line for us. And in this case, there were actually a total of 5 lymph nodes that came out to be positive, including these 2. So now in retrospect, maybe this was one of the lymph nodes, a relatively rounded shape, which probably might have been involved. And there are some other very small lymph nodes in the mesorectal fat, but we're limited by our definitions of involvement. And obviously, so again, in this cases, it is important to communicate with the times. You might not be able to report this by guidelines, but again, the idea is that the management of the patient should not be affected in any major way. So that is the crux of all medical science and imaging.
Can we see the T staging in this particular case?
The T staging.
T staging.
Okay. So in this case, again, like I'll just run through the axials. So yeah, tell me.
Yes. In this case, you also can show that.
Okay, yeah. So this is again, yeah. So because this plane is not very orthogonal, so if you look at the sagittal images, वो नीचे हैं. But this is again, in this case, you seem to find that there is bladder involvement, but look at the sagittals, okay? Yeah, but that's a good point. Everybody's looking at it very vigilantly. That is a good point. Yeah, we have a number of axials. Let's see if. No, I don't think I'm able to put the scrolling thing in.
So now there is flat planes between
Again, I'm not very sure because I'm not getting any good cross-reference lines. Let's see if I can get anything here. Yeah. So I think this is probably axials that we have acquired later, in which you can see the margin of the lesion and the bladder. Okay. So maybe a focal abutment, but this is the non-diseased part of the rectum. So we're not concerned about that. And the point where we have the lesion, you don't have definitely bladder involvement. And as sir was saying, when it comes to the T staging, so let's have a look at the T staging. So scrolling upwards. again, you have these speculations, you have this tumoral outbranching, which we called EMVI. You have some other areas in which you can see these irregular margins of the rectal lumen along. Let's see if coronals are dramatic in this case, because at times when our sagittals and axials are a little inconclusive. So yeah. Now, this might be a better image to visualize. Now look at this margin of the rectum that is involved by the tumor. Very irregular, sir. So there is definitely all these projections. So less than 5 mm or maybe up to 5 mm. So T3B, nodal status we've discussed. Sir, any other questions from anybody? Now I'll come to the last case that I'm going to show you. Now this again was a very dramatic follow-up for us, and an important thing, this is a post-therapy scan. Unfortunately, I don't have the pre-therapy MRI available today, but I do have post-therapy images. And this is just to give you a sense of how dramatic post-therapy imaging can be. And at times, it's very important to regain your composure after looking at the initial images, because you tend to overcall almost everything at first sight. So I'll show you some fat suppressed images just for a more visual effect. And then we'll systematically run through what went wrong and what we could have learned better from this case. So these are axial fat suppressed images. Now look at the rectal lumen, the rectal margin. A huge amount of submucosal edema. So a very edematous upper rectal wall. Now, if you look at this particular segment, this is not a very good image in terms of interpretation. But what I'm trying to show is that there are definitely, in post-therapy cases, we've also gone through that reporting checklist. There's a lot of fibrosis that happens. And after a certain amount of time, that fibrosis can mimic tumor also, because fibrosis is very irregular. It can, be adherent to adjacent structures. So there's a lot of distortion of the normal anatomy that we encounter in post-therapy images. So this is what happened in this case. I think if I remember correctly, this was probably a T. In this case, post-therapy, this patient came back for a reevaluation or a restaging MRI. Now, if you look at the rectal wall, obviously all these edematous changes that we've gone through earlier, all of this is expected post-therapy response, okay? Post-radiation, post-chemo, you have all this proliferative mucosal edema. But if you look at the rectal outline, that is still fairly intact. Now, as we're going caudally, we have a little bit of ill-defined hypointense signal that starts to creep in along the wall and the lumen. Further caudally, if you see, now we see that the margin of the wall becomes a little indistinct. And we have a sense that there is probably an indistinct clear fat plane between the left posterolateral wall and the adjacent MRF in this case. And as we go further caudally, now this is the point which we had a lot of discussion in our department about whether we should, overcall it in terms of the obliteration of fat planes with the levator ani. And ma'am, I would love your input on this as well, because in this case, so this was the segment that was most confounding. And if you look at the levator ani on the right side, so this is the right levator ani, and this is the left levator ani, and you can see that this is all thickened and irregular. So we have a very nice comparative point here. So the overall consensus was that maybe, the disease has not responded that well to therapy. And obviously fibrosis can be a confounding factor, but calling this fibrosis and calling it up and upstaging the disease, these are like hugely varied terms. And this eventually got operated, and there was absolutely no disease. So this was complete response. That was what we got to know. Now, the learning point, I think, in this case would be that if we look at diffusion more closely, again, we would want ADC maps. Now, these are, I'll just window it a little. Wait, yeah. So those are our diffusion images. And the point where we had a lot of confusion, if you look at this area, there was not a lot of restricted diffusion in this region. So this mild hyperintensity that you see, this is along the mucosal aspect of the rectum, and this is okay. But the point of contention was that all these areas in the lower rectum where we had all that thickening, and this is the area. So generally, there was not a lot of diffusion restriction happening. And we did a contrast also in this case, but contrast effectively is not very useful. Almost everything enhances if it's pathological, if it's fibrosis, if it's inflamed. So in this case, this was one of the cases in which we had complete response, but obviously the imaging was very noisy, very confounding. And now we revise it obviously in retrospect, but Another thing that we want to point out is that this patient also had nodes at that point of time, and this is how post-therapy lymph nodes look like. So you look at all these structures, these enlarged, lobulated. Now, how T2 hyperintense are they? So this is something that you would expect in post-therapy cases. You would expect brighter, very nicely rounded lymph nodes, and a lot of obviously pelvic soft tissue edema. Anything that anybody would like to ask? Chalo, thank you. I think Dr. Seema will share some of her cases.
The next one. Dhruv, those were lovely cases.
complex is totally spared in this case. Okay. So if the surgeon has to go in for eventual surgery, what will be the planning? What surgery can they do? They can do a sphincter sparing. They do not need to do a total APR. They can just do a low LAR. Okay, extra low LAR. Why I'm showing you this case is because we have the post-op of this also. I'm going to put both the images side by side. So this is of so this is your pre-treatment and this is post-treatment. So what do we look at post-treatment? You first look at the craniocaudal extent of the tumor. Has that reduced or not reduced? So you're looking at the bulk first. So there is no doubt the signal is change of the tumor. The extent of the tumor is gone down, the bulk is down. So we know there has been a response. Okay. Next, we move on to our signal of the tumor. So let's look at our T2 weighted images. I'm putting the T2 of the pre-treatment here. Sorry, this is the on your, are you getting it? Where my cursor is, that is the pre-treatment, okay? And this is the post-treatment. So look at the signal in the pre-treatment scan. What was the signal? It is intermediate in signal, okay? As expected for a tumor to be. Look at the signal here. What is happening in the post-treatment? It's becoming darker, okay? So dark is good. That means there is good response, there is fibrosis. The response can be of two types, either fibrosis or mucinous. So if a dark tumor initially becomes nice and bright, that means it has got a good response. Or it becomes nice and dark, that means there is fibrosis. Again, that is a good response. The intermediate signal is what we worry about, which we don't want in a post-treatment. Having said that, in mucinous tumors, those are bright pre-treatment and they still remain bright post-treatment. You may get fibrosis, but normally they stay bright. And we cannot differentiate a acellular mucin from a cellular mucin. So MR is very bad in case of mucinous tumors. In non-mucinous tumors, we are pretty okay for seeing the response. So now in this post-treatment scan, what I'm seeing, there is some intermediate signal still left. Can you see this? The rest of it is dark. So we know all this is fibrosis, but I'm not sure what this is. And in the post-treatment scan, this is what we have to look at is the diffusion weighted images. These can help you. So look at the diffusion. We basically, when we acquire diffusion, they had multiple B values. You look at the highest B value, but everything else gets suppressed. Now you can see the bladder has become dark. So this is a good image to look at it. And we still have some bright signal somewhere, the same area which was showing intermediate signal. So ADC is very important because if they are bright on diffusion and ADC, that is not residual tumor. So you have to have bright signal on diffusion and dark signal on the ADC. So let's look at our ADC images. So on ADC, you are getting these areas of hypointense signal. Okay, they're very few, like you can see it here. Okay, there is some areas of low. So this is some amount of residual tissue. We've already told you how we report post-treatment scans. You put a Y in front of the TNM staging. When you're doing pathologic, you write P in front, okay? So here we'll give you the T stage, the N stage, and the M stage. And we also give something known as a tumor regression grade. So that is divided from 1 to 5, 1 being complete response and 5 being no response. So this will come into a tumor regression grade of 3. That means there is intermediate response. So there is some residual tumor. So this is how you look at residual post-treatment scans. So let's go to our next case. So this ask us, is the CRM involved in these signet cell tumors? It's very difficult for us to say because we don't know, is this actually tumor going out or is this vascularity? So we always tend to overcall it and say, yes, we think CRM is involved because all this signal is going outside. And look at the fat plane with the vagina. So this is your vagina anteriorly. This is the rectum. There seems to be a fat plane. But these signet cell tumors are notorious to just spread without contiguous spread. So even if you have a good fat plane, we will definitely call involvement of the vagina because these lesions, the signal is exactly similar to that of the tumor. So this is the importance of showing you this case that signet cell tumors very commonly are mistaken for colitis. And even your biopsies can be negative. If you don't take a nice deep biopsy, and if a radiologist does not emphasize to the surgeon, no, this is definitely a tumor, please go ahead, repeat biopsy. We've seen 2 biopsies coming negative, and we say, no, go in for a third. We definitely think our level of suspicion is very high. And then when they go even deeper, they do get positive signet cell tumor. So this is one case you need to be really worrisome, and you really need to see this properly. And again, just emphasizing the point, initially we started off as a perineum scan. You can see the planes are all wrong. Okay, so this is a wrong acquisition. Then after we had changed the protocol and we went ahead and we said, let's repeat the study. That's when you get the right plane. Okay, now you're going absolutely perpendicular to the tumor. So this is very important. So here there is no nodal involvement. There is just some mucosal spread. This is a T4B stage because it's already gone to the vagina. So this is what I wanted to show you in this case. So let's see another one. Okay, so what kind of tumor do you think this is? Very good, Thamdi said it. Mucinous. Okay, so it's nice and bright. When you have such bright signal, we know this is a mucinous tumor. But what has gone wrong in this case is the patient presented late and you can see the tumor has actually ruptured. I'll just show you a better image. Totally. This was all this. I think I'll just show you another. So here, can you see that? It has disrupted the wall there. And the tumor has actually leaked out into the tissue. The wall discontinuity is totally lost. Okay. And now these tumors actually are very non-responsive to regular chemoradiation. And even if you wait and do the post-treatment scans, we really cannot differentiate that is this tumor or not tumor. Like I mentioned to you, acellular and cellular mucin are very difficult to differentiate on imaging. So here it is ruptured, gone out, the whole CRM is thickened. The lesion is above the level of the peritoneal reflection. You can see this is where the expected site of the peritoneum is because there was such a mess here. You can see this whole presacral fascia is thickened. It's totally involved. So this is a mucinous tumor with rupture. And just to show you that all the cases are not so complicated, they can be easier. So now tell me, where is the tumor? Can you see the tumor? Excellent. So this is in the upper rectum here. Okay. And let's look at it on our coronal images. Is the plane right? Have you taken the right plane? Why not? No, so we are taking basically 2 acquisitions, orthogonal. We are going perpendicular and parallel. Okay, so this is definitely going absolutely perpendicular to the tumor. So the plane is absolutely right. And here we need to differentiate, is this a T2 or a T1? Okay. So now in this case, you can see the outer muscle layer beautifully. We are lucky. Every time we are not so good at this, a T1, T2 is difficult on MR. It's basically the choice is endoscopic ultrasound, but here we can beautifully see this. So we know this is definitely inside. Now, whether it is involving the full thickness or not, again, we've been lucky. We can see a black thing. So we know this is a T1 and they operated upon this and this turned out to be just a adenomatous polyp. There was no malignancy. Okay, but for us, like I told you, radiologists are not sitting here to tell you that is this a tumor or not. This is the job of the pathologist. We are just here to stage the disease, and this is what we are doing for you. So anybody has any questions? Yeah. Mhm. Yeah, indeed.
There you cannot differentiate because of the endoscopic ultrasound.
Hmm.
The sensitivity specificity values for the endoscopic ultrasound and the MRI.
Okay.
Is there any other indications apart from the early rectal cancer where the endorectal ultrasound has the edge over the MRI?
Okay. So, now they do a TATME, a transcranial excision of thing. That is where endoscopic ultrasound is very good. MR is just helping you and telling you the distance, because there are certain criteria we need to meet. 8 centimeter from the verge involving less than 30%. I think you people will tell me this better. So that is where endoscopic ultrasound should actually be done. Because lots of times we've had surprises. We tell them, okay, it's only involving partial thickness. And actually for those lesions, we need to know SM1, SM2, and SM3. Okay, which MR cannot tell you. So that is where endoscopic ultrasound will score over MRI, and we should do. We unfortunately don't have it in our hospital, so they're relying on this. So lots of time they've gone in and then they have to repeat the surgery and do a revision surgery because there's involvement of the full thickness. So that is where it will score. Otherwise, the sensitivity of ultrasound is higher or equal to MR in the T stage. Okay. But especially for T1, T2, but it will not tell you CRM involvement. It will not give you a very good status of the extra mesorectal node. All the local regional spread, MR is far, far superior. So just remember only for T1 and T2, that is where we are looking at endoscopic ultrasound. Otherwise, for everything else, you do an MR. And by the NCCN guidelines, irrespective, you start with an MR and a CT for metastatic. If you have a doubt, is it a T1, T2, and you want to do a TATME, that is when you go and do an endoscopic ultrasound. Okay. I think with that we can end.
Your means this
Hmm.
high resolution MRI, what we are seeing now, definitely we have moved forward. But my question is, when you want to, patient comes with some scan done outside, most of clinically, they come with some bad scan or some scan outside. When you want to repeat a MRI
Hmm.
again, so that will help us clinically.
So we review
It's
scans
mostly the
and
type 2, type 3.
yeah,
This is the main
absolutely.
problem.
So lots of time, I mean, if they are not done in the right plane, we refuse to give opinions because, the surgeon is going to come and hold our neck afterwards. So we definitely ask for a repeat if it's not done properly in the right planes, but we do see some scans beautifully done in the right planes and with nice, without fat saturation. So we are good enough to give opinions on that. But I don't think the radiologist should even hesitate to repeat a scan, especially if they're not, because it really changes your management.
Yes.
So we do repeat them. Yeah.
Yes, and also I would like to point out, ma'am, that a lot of times it's not always the case that we are only dealing with T2 and T3A or B lesions. Sometimes even on outside scans, you have disease which is fairly advanced. So in that case, that is the only scenario in which we might be fairly confident in giving an opinion. But ma'am, as ma'am rightly said, that repeating a scan should be done because it's going to affect patient management very.
Sometimes it's the cost, but we even just charge very nominal and do it because after all, finally, it is the patient care which we are really looking for. Yeah.
Also, ma'am, that signet cell case, that also signifies that at times the role is not only staging, but also arriving at a diagnosis. Because in the face of a diagnosis of colitis and even imaging findings that mimic that, and with negative biopsies, you might be just tempted to, waver off course and say that this is probably
Yeah.
a sort of colitis.
So that's where your role of a radiologist really comes out. And if you tell them your level of suspicion is really high, then they should go ahead and repeat. Yeah.
Ma'am, T1 weighted imaging, should we do it or we totally rely on T2 weighted?
So we always do. I mean, I didn't go through the protocol. I thought you people would not be interested. So we do these high resolution T2s, like I showed you, all three planes. Then we do a T1 weighted image right from the level of the inferior mesenteric vessel and up to the symphysis. This you can even just do a T2, but we like to do a T1 because we've had surprises. We get melanomas. Melanomas are T1 bright. The management of melanomas is different. So we need to tell the radiologist, yes, this is a melanoma and not an adenocarcinoma. So we always like to do a T1 also. We don't do the staging wide FOV for the nodes we normally do. We use a T1 weighted image. So that is our generalized protocol, what we are following. Okay.
Ma'am, to take a call for low rectal cancers for intersphincteric resection, yes, sir. What are the points that a surgeon should be looking into that?
So again, the role of the radiologist is very important. We have to tell you whether the intersphincteric plane is involved or not. But this is still a very, very difficult area for us to do because it's so tight. So we sometimes, of course, we've gone wrong a lot of times, but luckily for us, none of the surgeons are doing intersphincteric plane dissection right now. I don't know if any of you are doing. You're doing it. That's excellent. So that we have to be absolutely sure that when we get a nice fat there, then we are very confident and we tell them. If we have the slightest of doubt, we say do not do an intersphincteric because the chances of recurrence go very high. But yes, this area is the most difficult for us in all. The mid and the high rectal tumors, I think we are pretty okay. But the low, we still are not very good. Yeah.
Thank you very much, all three of you. So I think just to summarize, I think the idea of doing this session was that rectal cancer management has changed. It is a multidisciplinary management, and I think trick is to apply the right tool at the right time in the right patient. And we all know that MRI of the perineum pelvis is the modality of treatment to do local staging. Unless you stage the disease well, you are not going to choose the right treatment for the patient. And unfortunately, even in tertiary centers today, we get patients from outside who come to us with PET scan, colonoscopy, biopsy, PET scan. That's the modalities. And obviously, everybody is short of cash. And as a surgeon or as a radiologist, you may think that this patient has had a PET scan. Can we avoid an MRI? I think don't fall into that trap. We have to not only resist the temptation of not doing an imaging, but also guide our colleagues that MRI of the pelvis is a must for any rectal cancer. You cannot proceed with the treatment without having a proper staging. And it changes the life of the patient. It also changes the life of a surgeon, because if a proper patient has been given a proper treatment, the surgery obviously will become much easier at the right time when you choose to operate. And now today, so many combinations of radiation and the chemotherapy are available. Whether you need to give a total neoadjuvant treatment to a particular patient will obviously be guided by MRI. So I think that's a very, that was the whole idea, that we should be aware. And second, unless you know how to really read an imaging, you cannot ask the right questions with the radiologist. So you don't have to be an expert in reading, but you must have a fair idea what you are looking at, what questions to ask radiologists. Then you can stimulate a radiologist to do a better reporting of a particular case. There's no doubt about it. I think you will agree with that. So I think very good session. Should we go ahead with the lecture or break for the tea? I think it was very intense. Maybe we can break for tea. Yeah. Okay. So let's join for tea, and then we'll come back for a very interesting talk by Dr. Neeraj Dhamija, how to handle a pathology specimen. I think rectal cancer is one of the surgeries where the quality of surgery can be measured by a pathologist. So how do we handle a pathology specimen?
Please assemble for the next session. We will be starting in next 3 minutes. We would like to invite Dr. Neeraj Damija for the next session, how to handle pathology specimen and its correlation with the quality of surgery. Dr. Neeraj Damija.
Thank you and good morning. And I thank Dr. Deep Goyal for bringing me out here in front of you in the august audience. And after the black and white pictures, I would probably fill some colors to these slides. So this is a normal pathology specimen of a rectal cancer. You can see here at the anterior aspect, sorry. You can see here at the anterior aspect, a blue solid line, which demarcates the line of peritoneum. And on the posterior aspect, this line as a blue dotted line goes quite high up along the vessels. So there is a disparity between the anterior investment of the peritoneum and the posterior. And this is how the specimen is to be retrieved. So what to expect from the surgeon? So in pathology, to do a good, in the pathology specimen, to do a good surgery from a surgeon, it is expected two things. You have to be a too good surgeon. One, you should be able to resect a good TME specimen. And second, a good circumferential resection margins. In the next few slides, we will see what these two things mean. As depicted in the previous colorful picture, and this is a diagrammatic representation of the same, the anterior peritoneal investment is seen here, and the posterior is seen in this diagram. You can see posteriorly, it forms a triangular shaped structure because here lies the vessels, and along with these vessels lies the important lymph nodes, which are to be resected. And to do a good surgery, you have to be sure that you are ligating the vessels at the highest point. Because once you ligate the vessels at the highest point, obviously you're taking all this triangular shaped peritoneal investment and the mesorectal tissue below that. And what is circumferential resection margin? This is very important to understand that it does not only include the tumor from the margin of resection. If this black line denotes the margin of resection, it is not only the distance between the tumor to the margin of resection, but also to any positive lymph node or any positive blood vessel which is having tumor deposit. So it is not only the tumor, but the tumor cells, which will be discussed in the later pathology slides, which is important to resect. So you have to be a twofold, it has to be twofold goodness in you. You should be able to resect it completely with a good circumferential resection margin. And it is a level 1 evidence which says that the plane of surgery in rectal cancer predicts a local recurrence and the prognosis in patients. So what is the plane of surgery in this section? The commonest term used is the mesorectal plane, but this is not very common. If you're not a good surgeon, then there are other planes which you can go into, which are not desirable. So in a mesorectal plane, you will see a shiny fascia covering over the CRM with no defects. Can you see this area where there are no defects? But if you go deeper down to the resection, you can have these areas of defect in the mesorectum, which are marked by a blue arrow here. You can see on the left side, this is a shiny area with virtually no defects, but on the right side, here there are defects in the mesorectum. So this is called as an intramesorectal plane. There is another plane if you go deeper and dissect the muscles of the rectum along with it. This is called as muscularis propria plane. So on the specimen only, you are able to assess whether you have gone through the plane, the mesorectal plane, or there are defects, or to the muscle which is visible. This is a muscle of the rectum. If you go down to doing a APR and extra levator resection is done, then you can see the lower portion of the specimen is covered by muscle, but this is not called as the muscularis propria plane, but this is called as extra levator because this is a levator muscle, and you have resected the specimen at the levator level. But if you plan not to resect the levator along, then this is the sphincteric plane, which is a classical surgical waist. Here you can see a classical surgical waist where the levators are removed and there are only sphincter muscles which are there at the lower half of the lower part of the specimen. The surgical waist is here shown by the blue arrow. And this is what you will never desire of. This is a submucosal or a perforation plane. So this is a specimen which is being shown while dissecting. It was opened up and you are able to see the visible mucosa inside and showing a larger anterior perforation with a blue arrow and a very irregular and multiple defects in the circumferential resection margin. This is all gross. So there is a 3-point grading system which grades the surgeon and its dissection based on these planes. So if you have gone to the mesorectal plane, it says you have done a good surgery, which is having an intact, smooth mesorectal surface with only minor irregularities, and any defects must not be deeper than 5 millimeter. There should be no coning as seen in the previous specimen, and there should be a smooth CRM on slicing. The intramesorectal, which is called as a moderate surgery, where you have not gone to the defect of the muscles, and the defects are a little deeper than the 5 mm, but the muscles are not bared. The third is the poor surgery, where there's little bulk of the mesorectum with defects down onto the muscularis propria and a very irregular CRM as seen in the previous slides. It also includes the perforation or a perforation plane. This is what we do. We dissect the specimen and send it to the pathologist. But I was discussing with my pathologist and they say they probably spend more time on the pathology specimen of a rectum than it is spent by us while dissecting it. So what they do, once you send the specimen, it is always better if you can send the specimen as a fresh specimen. But most often we put it into formalin. I asked this question from a pathologist, then how can we send this fresh specimen? They said it is basically the time of fixation. The time of fixation of specimen is 48 hours. So it is ideally if you can give the specimen as a fresh in a fresh container and they gross it in a fresh specimen and then fix it to assess the quality of the mesorectum. So what they do is they first paint the non-peritonealized areas with India ink. This is the anterior part as shown, and the posterior part. You can see both the bare areas which are not covered by peritoneum are being painted with India ink. And then they start the deciding whether there were any breach in the surface of the circumferential resection margin or not. What is the technique of fixation or opening of the specimen? This is what we always do. We tend to see the specimen after the resection on table. Sometimes some people might be doing it to open the specimen and see how the tumor is looking. But it is not to be done. What should be done is, even the pathologists, what they do is, they open the specimen along the anterior aspect, just to the top of the tumor, or if there is also a margin below the tumor, they open the specimen. But the circumferential part of the tumor to assess the circumferential resection margin, they leave it like that. So what they do is They pin the specimen on the chalkboard, place loose formalin-soaked gauze wicks into the unopened ends of the bowel, and fix the specimen for at least 48 hours before they can start grossing it or processing it for microscopic examination. So they open it, they put some gauze pieces from above and down, which are formalin soaked, pin the area, pin the specimen over the chalkboard, and keep it there for 48 hours. The next thing is to slice the specimen. So what they do is they slice at 3 to 5 interval, which are these are the horizontal slicing of the specimen to obtain a certain picture like this. So they inspect the slice to note the extent of the tumor, the closest distance of the tumor to the CRM, any obvious positive nodes, and distance of any positive nodes from the CRM. As I've told you, it is also important. Not only the tumor should be away from the circumferential resection margin, but also positive node. And fat away from the tumor should also be examined to detect a lymph node. So they prepare at least 5 blocks from these slides, 3 blocks from the tumor showing the closest CRM, and 2 blocks of the tumor showing the luminal aspect. All the lymph nodes, they carefully count all the lymph nodes, and it is to be seen that if the lymph node is crossing 2 cut margins, they should not be counted twice, because the counting lymph nodes is also important. We'll come to the later slide for that. The proximal and distal resection margins are also seen. The distal margins include both mucosa and the mesorectum. Blocks from muscular mucosal margin may be omitted if the tumor is greater than 3 centimeters away from the resection margins. So there is also a peculiar way how they mount it over a chalkboard. On the upper left part is the proximal, and the lower right part is the distal dissection, distal part of the rectum. And the quality of the mesorectal tissue resected margin is assessed accordingly. Sometimes you also see that on a cross-sectional image, these are the 2 very important images, which show the specimen showing involvement of the circumferential resection margin on a cross itself. You can see on this side. So there was an MRI done on a patient who has received a neoadjuvant therapy, which said that probably there is a fibrosis and there is no involvement of the CRM. But here you can see a narrow streak which is going till depth, and here the tumor which is reaching till the resection margin, and on microscopic examination it was said to be positive. You can also prepare a larger slide where it allows us to measure the distance between the resection margin and the tumor. So the minimum, what is CRM? It is the minimum distance in millimeters between the tumor and the non-peritonealized circumferential or radial margin. This must be recorded from the histological slides. And it is said that about 5 to 36% of cases, the CRM is positive for tumor, and this is associated with significantly higher rates of local recurrence and cancer-related death. And again, on CRM, we also label the specimen or label the surgery as either complete, nearly complete, or incomplete, where when the CRM is irregular, you said the surgery is incomplete, and it is irregular in nearly complete, but smooth and regular incomplete. I also asked my pathologist yesterday only, so is there a standard millimeter of distance which says that the CRM is good or not? He said, no, it is either positive or it is involved or not involved. So these are the 2 very important things. You have to measure the distance, but also even it is 1 millimeter, 2 millimeter, either it is positive or not involved. You can also do this thing while assessing the CRM if the pathologist is not available to evaluate the specimen when you have resected it. You can instill some dye and see for any punctate leakage or gross leakage of the specimen. You can instill the dye inside the specimen and see for any leakage to assess your quality of circumferential resection margin. So when it comes to microscopic examination, you have to do a tumor typing based on adenocarcinoma, signet cell carcinoma, mucinous, or undifferentiated. The WHO classification based on the classification grading is based on the percentage of the tumor showing formation of gland-like structures. When it is well differentiated adenocarcinoma, it shows glandular structures in more than 95% of the tumor. When the glandular structures are present only in 50 to 95 glandular structures, it is moderately differentiated, and poorly differentiated if it shows that there are only 0 to 49% glandular structures which are present. The pathological tumor classification, T classification, is to be done on these specimen, and which everybody knows it is carcinoma in situ in TIS. Tumor invades the submucosa in T1. The tumor invades the muscularis propria in T2, and tumor invades through the muscularis propria into the perirectal tissue in T3, or T4A when the tumor penetrates to the surface of the visceral peritoneum, and T4B when the tumor directly invades or adherent to the other organs. The nodal classification, when there is metastasis to 1 to 3 regional lymph nodes, is T1, it is N1. N1A is metastasis to 1 regional lymph node. 1B is metastasis to 2 to 3 regional lymph nodes. Or if you see tumor deposit in the subserosa, mesentery, or non-peritonealized pericolic or perirectal tissues without regional nodal metastasis, it is N1C. In N2, it is metastasis in 4 or more regional lymph nodes. Similarly, 2A and 2B are divided in 4 to 6 and metastasis in 7 or more regional lymph nodes. Lymph node histopathology is also very important, as a minimum of 10 to 12 is considered as a standard of oncological resection, and all defined lymph nodes must be microscopically examined. You should always examine the venous and the small vessel invasion, which must be reported, and its anatomical location should be specified as intramural or extramural. There should be presence of histologically confirmed distant metastasis should also be seen, and presence of any relevant coexisting pathology should also be noted. If there is a microscopic residual tumor status, it must be reported, and the response to treatment is graded as below. This is also very important. Once the patient has received a neoadjuvant therapy, you will see if there is response to treatment or not. Grade 0 is complete response, where there is no viable cancer cells. Grade 1 is moderate response, where there is single cells or a small group of cancer cells which are viable. Grade 2 is minimal response, when there is residual cancer outgrown by fibrosis. And grade 3 is poor response, which is minimal or no tumor kill, but extensive residual cancer is present. After doing the gross and microscopic examination, you go on to the IHC and the gene mapping. The most talked about is the microsatellite instability, and it is found in about 10 to 15% of sporadic cases. And the presence of MSI predicts a good outcome in colorectal cancer. So this is actually true that the pathologists do a lot of work to grade how you have done, and a careful macroscopic evaluation of a total mesorectal excision specimen by the pathologist plays a key role in the assessment of the prognosis in the patient with rectal cancer. An assessment of CRM in TME specimen is the most significant predictor of local recurrence. The quality of the excised mesorectum is the key factor affecting the risk of local recurrence in patients with a negative CRM. And evaluation of the TME specimen provides important feedback on surgical technique to surgeon. So we must always go and discuss after the day of surgery with this pathologist to grade our surgery, how good we have done, and it will definitely predict the outcome. In our hospital, we uses these 2 templates which are available, which is College of American Pathology Standards Protocol for examination of a gross specimen and microscopic examination. This is roughly about a 30-page document freely available on the net. And another for biomarkers is about 15-page document available on the net. This is just a checklist so that you don't miss anything. And once you don't miss anything, that means you have correctly evaluated the specimen. Thank you. If there are any questions.
high risk patients, when the patients have not responded well to treatment, post total neoadjuvant treatment, you see on MRI that the circumferential resection margin can come out to be positive, the nodes are still there. Do you change your strategies for surgery after seeing this?
No, strategy for surgery remains the same. The primary aim is to excise the tumor in toto. But if you're saying that it is inoperable or it is involving the adjacent structure,
No,
then
no adjacent structure involved. The CRM might come out to be positive. On MR, you are seeing that the tumor is reaching up to mesorectal fascia, even post TNT.
yeah, obviously, if you have to resect the tissue complete. Even if the CRM is positive, that will define the prognosis of the patient. But if you have already decided to operate on this patient, then this will give you an idea that since the CRM was positive, then the prognosis of the patient will not be as good as if it was not positive. And if there is no response to the neoadjuvant therapy, then it's also a kind of a blow to the patient's prognosis.
I think what you're trying to ask is that do you change the strategy while as a surgeon? Obviously, you have to go for extended sections. Depending upon what area seems to be involved, if suppose in men it is a seminal vesicle, you would like to remove the seminal vesicle, which is not a normal protocol of a TME. So if prostate is involved, you will probably shave if you think it.
Pelvic accentrations
or
and all.
you do a prostatectomy, then you may need to do an accentrations. So depending upon what area is involved, male, female, you will have to change your strategy and go for extended sections.
As a surgeon, our aim is to remove all the possible tumor if you are going for surgery.
So Neeraj is a surgeon and you would be wondering why Neeraj is taking a lecture on the pathology specimen. But believe me, I have heard a lot of pathologists and then I heard Neeraj taking a lecture. I thought he's done a very decent job, and I think a big cheers for Neeraj as a surgeon.
Thank you.
About
Thank you.
pathology. And I think it's also a lesson for all of us as surgeons that there is an accountability for us of a procedure. Gone are the days that we can do anything in the abdomen and nobody knows what we have done. And so I think it's very, very important to understand there are quality measures in this particular operation, and we must train ourselves to do that. And there is somebody who can, sort of measure your quality, and they will give it in writing that your quality of a specimen was how 1, 2, 3. So I think it's imperative for us to continuously train ourselves and aim for excellence. And that was the whole idea of this lecture. Any questions or any comments? I think I would have.
A very stupid question because I am not a surgeon. So first of all, congratulations on the excellent talk.
Thank you.
I just wanted to know, when you do a LAR, do you mark and tell them this is the upper limit, lower limit? in the
Yes, yes,
specimen?
we do.
You do that.
We do.
And even
We should do it,
anterior
yes.
posterior?
Yeah.
Okay.
But obviously, once you have done a good LAR specimen resection, these are the standards. These are the kind of pictures you see.
Normally,
peritonized and non-peritonized.
proximal margins are not marked, Seema, but they are very, very obvious with the specimen. Yeah. But if you have any doubt of any area, circumferential margin or posterior end.
Yes, yes. Then you
So
mark.
normally a good center, the protocol should be that surgeon delivering the specimen to the pathologist, or sometimes it doesn't happen in our center, but pathologists come over into the operation theater to receive the specimen.
The pictures are so obvious that, yeah. Yes, yes. Thank you. Thank you, sir.
Thank you, Neeraj. I think we move on to now the next lecture on the energy devices and stapling devices. I will request somebody from the Medtronic to come forward and talk to us about different newer stapling devices and energy sources.
Meanwhile, we will request the people who have registered for the suturing competition to go on this side so that we can start simultaneously the suturing competition. And the people, please. Time like that. And we will be simultaneously starting in a batch of 5 participants, the robotic session hands-on. So we will be displaying the list, people who will go as first batch. So we will request
Thank you.
Just waiting for these. Thank you. And hello to everyone. My name is Lakshan and I'm from Medtronic. I represent big Medtronic team that we have, who we have here today. And we must thank from the bottom of our heart to all the organizing committee members, including Dr. Deep Goyal, for giving us a chance and to showcase everyone the power of products that we have in Medtronic. So over the next almost 30 minutes, we would like to show the different kinds of products that we have in surgical stapling, access instruments, and energy as well. So I'll be taking up surgical stapling, access, and hand instruments. But before I begin, I would like to share with everyone that after the presentation, please feel free to come to our booth and have a hands-on on not just the robot that we have here. We also have a surgical robot Hugo here, the console. But along with this, we also have endotrainers that we have kept. We have kept about 5 endotrainers workstations, and with endotrainers Hugo robot, we also have the latest surgical stapler Signia, and we also have the latest energy systems as well. So I think it's a very good opportunity for all of us to get a feel of all these latest surgical products. I'll begin my presentation. So Medtronic is a company that deals in lots and lots of products. Like we love it. We love by saying that we deal in products from head to toe. So as you can see, from heart to to the nerves and to the blood vessels to surgery. We are present almost in every segment in human body. I'll start with the laparoscopic stapling. So these are the staplers. I'll just would want to go back, from 1990s onwards when the endostapling word had started. So previously we used to have single-use endo staplers. Then came the cartridges. In 2005 onwards, those were the straight cartridges. Then came the articulating cartridges. Now these cartridges that we have house what we call as staples. So staples are present within these reloads or cartridges, which are then stapled on the tissues. There is a knife, which I'll show you in these staplers. So now the journey continued, from 1990 onwards to 2010. And all of us, like, we know that the mobile phones became smart. So that's how the devices also became smart. The devices today, even what we have, Signia, has artificial intelligence. AI, all of us know it's quite a buzzword in market. And Signia, that we launched globally in 2000, near about 2017 end. In India, it was launched in 2019. So yeah, I mean, if you look at 2012, we had iDrive, which was our first generation smart surgical stapler. Then came the radial reloads, which are for ultra low LARs, which you see here in 2012. These are again tri-staple. Now, what's tri-staple? I will actually share in my next slide. Then we had, in 2014, almost 9 years before, we had launched buttress material reloads. Now, there is a polyglycolic acid material on top of a reload. So this was launched in 2014. Over here, as you can see, that is endo GIA reinforced reload. Then came Signia in 2017, and then we launched a circular stapler with 3 rows, triple circular, tri-staple circular stapler. Now, let's see what tri-staple is. Tri-staple by definition sounds like it's 3 rows of staple, which it actually is, but there is a difference. The catch here is, in tri-staple, as you can see in the leftmost picture, the inner layer, the inner staple on either side of the cut line is the smallest. The middle one is a bit bigger, and the outer one is the biggest. That is actually tri-staple. So it's actually called varied height staple, or in our journals, it's also called graduated height staple, or GHS. On top of it, there are colors that give us an indication as to where we can use. Now, if we encounter a thicker tissue, then we will use black. What we have here is purple. Now, the difference between black and purple is for medium thick tissues. The innermost staple has staple height of 3 mm. The middle one will have 3.5, and the outer one will have 4. That's for medium thick tissues. But if you're encountering extra thick tissues, let's say lower rectum or the pylorus, so in such regions, it's ideal that we use a thicker staple or thicker open height stapler. In that case, the color changes from purple to black. And in black, the innermost layer is 4. So it starts from 4. So it's 4, 4.5, and 5 mm. Outer one is 5 mm, which is the highest open staple height in any lap stapler. Now, what does it actually do? Now, these were all the features, but what exactly it translates to? It translates to lower stress when you put on during firing. So the inner tissue layer will have a lower stress towards the cut line, so that it allows the perfusion, so that it allows a better perfusion towards the cut line, which is there in the second picture. When you have a better perfusion, the tissue healing takes place, the necrosis doesn't occur, and the chances of leaks reduce. That is the main motive about the main agenda behind having the tri-staple framework. And then finally, the better performance in variable tissue thickness. There are lots and lots of surgeons who are okay using purple across a variety of tissue thickness whenever they are not sure of it. Or we have seen that the chances of leaks also reduce with this. So it also helps in lesser number of coats, so that one shouldn't get confused with. These are a variety of reloads. These are called special reloads. We call it specialty portfolio. On the left side, for ultra low LARs, it's called a radial reload. Then comes the curved tip, which is good for vascular stapling. Now, the color that we see here is tan, and tan color is for vascular stapling. Then we have black, the one that I was mentioning. So wherever it's tan, purple or black, it's always tri-staple. It's always tri-staple. And we know tri-staple is not just 3 rows, it's 3 staggered rows like this. The middle one is smaller. Sorry, the first one is smaller, the middle one is a bit bigger, and the outer one is the biggest of all. And then finally, we also have 30 smaller reloads to reach tighter spaces. And then finally, a reinforced material reload as well. Good for hypertensive patients and stapling in obese patients, and of course in bariatric. Now, these were the reloads. And with this reload, we also have, of course, bigger portfolio, I would say even bigger than this. That is a normal radial reloads. Sorry, normal linear reloads, right? Simple plain purple reload, or first generation blue, green, white, these kind of reloads that you would have seen. Now, blue, green or white are single staple height reload. So all the staples will have same staple height like this, right? But tri-staple will be like this. So that's the difference. The blue, green and white will be like this. The tan, purple and black will be like this. So that's the difference. Yeah.
The difference between 3 rows staple and 2 rows staple. Is there any data to show that this one is superior, and in what terms?
So between 3 row and 2 row, so I mean, it all started from 2 row, but where we are actually moving is, we are moving towards vascular 2 rows, and we are moving towards a 3 row for tissues. Because we've just launched, I mean, we'll be launching a new reload this year, which is called small diameter reload, which is actually world's thinnest 2 row vascular stapler. I mean, to answer to your question, when we talk about tissue security, then definitely 3 row is preferred. And when we talk about vessel security, then 2 row is also okay. I mean, we also have 3 row curved tip tri-staples here, but if you want to reach tighter spaces, there we can actually have 2 rows as well. So 2 rows are ideal for vascular and 3 rows are ideal for tissues. Now, these all were the reloads. It's like those cartridges for our razors. But where is the razor? Where is the Mark III razor? Now, this is the Mark III razor. Now, this is called universal gun. Each gun, I mean, it comes in 3 sizes. The short, the standard, and the XL. The short one is for open cases, or it can, you can also use it for thoracic cases. The medium one is for colorectal cases. It could be used in lap colorectal cases. The outer, I mean, the biggest one is XL gun, which can be used in any obese patient undergoing laparoscopic surgery. It could be bariatric or even other surgery. Now, the best part with endo GI universal gun is any reload. I mean, we mean any reload that Medtronic has launched till date. That's why it's called universal gun, can be attached. So any color, any shape, any size. Imagine 30 mm, 40 mm, 45 mm, 60 mm, blue, green, white, tan, purple, black, curved tip, radial, reinforced, whatever you call. Everything can be attached with one gun. You don't have to worry about any other gun. There is no other gun. Sorry, there is no other gun. So this is the only gun. Now, on the same platform, we launched universal powered, reusable and rechargeable smart stapler. Now, this is magical. This is the latest generation. This is the AI of surgical world. There is no other company globally that has AI in a rechargeable laparoscopic device. Now, this is Signia. This is world's first rechargeable, reusable, smart, fully powered intelligent stapler. Now, these are pretty strong words. It's rechargeable because you can actually recharge it in 3 hours, like a smartphone. And then you can use it for up to 18 hours. It is reusable for 300 patients. 300 patients, 300 cases, you can use it. And there is a screen on top of it which shows you how many cases are remaining. It's smart because it decides the speed on its own. In manual guns, the speed is in your control. But in this smart AI gun, smart AI stapler, which is Signia, the speed and the force is in the hands of Signia, not in the hands of surgeon. It's fully powered because there is no other gun which is fully powered. Jaw opening, jaw closing, clamping, firing, jaw and articulation, roticulation, everything is powered. All the 5 functions are powered. And then it's intelligent. Why? Because I was sharing that it has got a technology called adaptive firing technology, which decides how fast or how slow it should fire. Now, we have moved from from saying, so there were days when we were saying it's just powered, but we've actually moved towards smart, reusable, fully powered and intelligent stapler, which is Signia. These are the components. You can see all these components outside. That's we have all of these today. And then there's a small video around Signia. Thank you. So as we saw that, as Signia encounters a thicker tissue, even in the middle of the firing, it will slow down. That's the beauty of it. That's the biggest part. It will slow down on its own. For thicker tissues, it will go slower. For thinner tissues, it goes at its optimum speed. Again, the same thing. It's got adaptive firing technology. It does about 1,000 calculations every microsecond to decide its force and speed. That is the best part. Human brains can't do that so quickly. It's got 3 different zones, zone 1, 2, and 3. If it encounters thicker tissues, it will move to zone 2 and 3, which is slower zone. It will fire, but it will go a bit slower. If it feels that the tissue is too thick for the reload that you have attached, if it feels that the tissue is too thick for the reload that you have attached, it will not fire. It will show you zone 4, which is a red zone, where it will ask you to upgrade your tissue, the reload. So that's a safety mechanism. This is a small porcine study where it was showcased that for very thick tissues, which is on the extreme right of the bottom x-axis, the chances of malformation was at 25% for faster speed. So for a very thick tissue, if you go fast, let's say you have a thick tissue and you're going like in a manual gun, you're going fast. So there's a 25% chance that your staples will be malformed. So, and for a thicker tissue, it is always advisable to have a slower speed. And that's why Signia fires slower for a thicker tissue. Yeah, so, sorry. Yeah, so powered rotation, articulation, firing, jaw opening, jaw closing, everything is powered. massive use is 300 cases. You don't have to worry about 300 different guns, one gun and 300 patients. And the best part is, again, the same thing. Any color, any shape, any size, any specialty, any generation, all Medtronic reloads can be attached with one gun. In fact, Medtronic doesn't have any other gun. It's just two, manual gun and smart gun. With both guns, you can attach anything. 60 plus reloads, as I said, universal reload. Now we have just completed the lap stapling. I'll move to the open stapling. I'll try to be a bit quick here. So we in tri-staple we have so there was a technology. I mean, there is a technology called tri-staple, but we also have a technology called DST series, which is directional stapling technology, which is basically nothing but your proper B-shaped staple formation. Now, this is the most commonly used stapler. It is for open surgeries. It's called DST GIA stapler, gastrointestinal anastomosis. Now, this GIA stapler is also here today. Here you can see the cartridge is blue, which means that it will have two rows. So blue will be, this is, wait a minute. I hope I have everything. Yeah. And it has got fires on either side. And there is a new tri-staple reload, which is the 3-row one, right? And in that, that will come later. Now, this is for linear stapling in open cases. Now, this is a hem stapler. This is called DST hemorrhoid stapler. This is quite a different stapler because it is used for piles or hemorrhoid surgeries. It is the only stapler in market that has got a detachable anvil. So this anvil can be detached. There is no other stapler like detachable anvil. Then we also have a circular stapler. Now, this is a 2-row circular stapler. This circular stapler is called EEA stapler or end-to-end anastomosis stapler, which is DST. But we also have a 3-row circular stapler. This we launched last year. It's doing quite amazing work in India. And this is quite smooth it's quite smooth in firing, and it's quite strong because it's got 3 rows. There is no lumen size reduction with this. It's the same lumen size for the same size. Okay. The best part with all our circular staplers, be it 2-row or 3-row tri-staples, is that its anvil tilts after firing so that you can easily remove it. You see this picture in the green highlighted box. The anvil after firing tilts like this, so you can take this stapler easily out. Now, yeah, so again, purple as well as black. This is 3-row tri-staple circular staplers in purple as well as black. So purple is for medium thick, black is for extra thick. Then comes another class of circular staplers. These are called TS stapler. The original name is thoracoabdominal because these staplers are quite unique. All the staplers that you saw till now had knife, but this one doesn't have a knife. This is a TA stapler. Basically, you staple on it. It's a stapler. It's not a cutter, right? So you staple on the tissue, and then you use the knife to cut the specimen side. So that's how it is used, and it's quite handy. It's actually quite economical wherever you have to just staple and not cut. So this is a stapler and not a cutter. Then we recently launched a 3-row GIA stapler. So we just saw the 2-row, which is DST GIA, but we also launched a tri-staple 3-row stapler. Again, it comes with tri-staple technology, both purple as well as black. 50% more staples, and of course, tri-staple has higher perfusion. I would just like to go to trocars. This is again important. Yeah, so we also have trocars 4th generation, bladed, optical, blunt, bladeless. So all these trocars are here. It's here in the stall. You can just go through them. These are commonly used in laparoscopic surgeries, trocars as well as hand instruments. Now, this is a quite interesting device. It's called Versa1 fascial closure system. This is the only trocar in market that has a fascial closure. It closes 5 mm across the wound. So a trocar with a 5 mm closure device. There is no loss of pneumoperitoneum when you're doing the closure in a laparoscopic surgery. It's there with this device. Now, quite interesting devices, which is wound protectors. Now we also have a big range of wound protectors. There are 5 sizes available, and yeah, so small, extra small, medium, large, and extra large, ranging from 2 centimeter to up to 11 to 17 centimeter. In fact, the largest one can be used in C-section surgeries. It's getting used in Hyderabad in C-section surgeries. Again, you can see here, a surgeon using Signia in a thoracic case with surgery sleeve wound protector outside. Big portfolio of hand instruments and clip appliers. Now these are clip appliers, preloaded clip appliers for open surgeries. It's called premium surgery clip. In one clip, in one device, you have about 16 to 30 clips in different sizes and staples. So there are about 4 different variations available. Now, if you want to do the same preloaded multi-flyer clips in laparoscopic surgeries, it's this. It's endo clip. 16 clips, and all 16 clips are loaded. You don't have to take out every time. You just can, put the clips laparoscopically. And it's the longest clip in a 5 mm device. This is 9.1 mm, the pin height. Okay, now this is a very interesting device. It's actually very interesting. It's called endo stitch. It can do laparoscopic suturing for you in 10 mm trocars. All the surgeons, mostly bariatric surgeons, use it a lot. We also have some gynecologists who are using this. It's called endo stitch, and few urologists also use it. So endo stitch can be used in laparoscopic suturing. Finally, for specimen retrieval, we have endo bags, and we also have specimen retrieval endo catch hold. It can be used effectively in laparoscopic surgery to take out this specimen. A variety of graspers, 5 mm, 10 mm scissors. It's there. You can use all these hand instruments on Medtronic booth, and we have it placed in the endo trainers, dissectors, and yeah, that's about it. This is anti-fog. Few drops of this, and we guarantee there will not be any fog on your scope for the next 15 minutes. For 1 hour, for 1 hour you don't have to clean anything. So it's quite cheap. It's like 500-600 rupees. And that's it. Few drops. There is no fogging during the surgery. Thank you. I'll hand it over to Asad to take us through the energy. Thank you.
Yeah, so good afternoon, everyone. My name is Asad, and I represent Medtronic. Thank you so much for giving this opportunity to present the energy portfolio for Medtronic division, which we have. So talking about the latest innovations from Valley Lab energy portfolio of energy devices, we have the electrosurgical units, which is our FX8 generators. Starting from the year 1968 till 2018, we had all the new generators in the market as placed right now. So this is Valley Lab FT10. This is a combination of monopolar as well as bipolar tissue vessel sealing and underwater bipolar resection, as well as monopolar resections. The best part is this works in the principle of tissue fact tissue sensing technology, which senses the tissue's impedance constantly 434,000 times a second and delivers the output energy in the precise manner with a standard deviation of 1.75% only. This also has a monopolar 1, monopolar 2 receptacle, as you can see, and we have bipolar receptacle, also the ligation receptacle, along with the bipolar underwater resection. And tissue bundles and lymphatics up to and including 7 mm. So this is a 23 years plus of legacy with 25 million procedures done and 1,300 clinical papers have been published over 65 countries. As you can see, there's a small video of how LigaSure works.
Clamping on tissue compresses the vessel walls. Current begins to flow through tissue, creating heat. Native tissue proteins denature, while water turns to vapor and escapes. LigaSure technology fuses the intimal walls of the vessel, resulting in complete lymph occlusion.
I'll just replay it once again.
Clamping on tissue compresses the vessel walls. Current begins to flow through tissue, creating heat. Native tissue proteins denature, while water turns to vapor and escapes. LigaSure technology fuses the intimal walls of the vessel, resulting in complete lumen occlusion.
So the beauty of this product is there's an inline button activation. There's no separate button. Once you clamp and grab the handle, it automatically delivers the energy, and based on the tissue effect sensing technology, it senses the output and delivers the precise energy for proper vessel sealing. This also has an independent scissor, which you can use. It depends upon the surgeon whether to use the scissors or not. So we have all the variety of hand instruments available with us, starting with the LigaSure Maryland hand instruments. We have the blunt tip series. We also have a LigaSure Maryland L hook, which is a specialized LigaSure hand instrument, which is a combination of LigaSure plus a monopolar L hook. So in a single device, you get both the functions of monopolar as well as LigaSure. And we also have a product called LigaSure Impact, which is basically for the urological cases and gynae cases. And we have a specialized LigaSure small jaw, which for the used for the surface procedures. The best part about the what is important to the instrument is that the thermal deviation or the thermal spread. The best part about LigaSure is there's only less than 2 mm of thermal spread, so there's zero chances of damaging the neighboring tissues. So this is our trademark product called Sonicision cordless ultrasonic dissector, which requires no bulky generators or cords. So you're not limited to a single cord, and in the OR system, this is a completely independent hand instrument. I'll just quickly show it to you how it works. So this black part, this is the generator of the instrument. This is the hand instrument, and this is the battery. It takes less than 30 seconds to assemble. So once you put in the battery, it is ready to work. So this is now an independent using ultrasonic dissector, which requires no cord or no external generator with a single button activation. With a single button of activation, you get both the modes of minimum mode, which is for coagulation, and the maximum mode for the vessel for the dissection. When you click it for the first time, this is the hemostasis mode. And when you click it further, this is the dissection mode. This is Sonicision 7, which comes with a 7 mm of vessel coagulation. We also have a product called Sonicision 5, which comes with the 5 mm of vessel coagulation. And talking about the generator, it's a reusable generator, sterile, which comes for 150 cases. The battery is also reusable, but it's non-sterile, which comes for 200 cases, and the hand instrument is disposable. So there's a small video for Sonicision, the function of Sonicision.
Experience the evolution of freedom of movement. From the trusted name in cordless ultrasonic dissection devices. Introducing the redesigned Sonicision curved jaw cordless ultrasonic dissection device. The cordless design reduces the challenge of managing cords in the sterile field and provides freedom of movement and mobility during your surgical procedures, contributing to a safer and more efficient OR. Available in 4 shaft links to help meet your specific need, the Sonicision curved jaw cordless ultrasonic dissection device enables secure vessel coagulation and efficient dissection in open and minimally invasive surgical procedures. The tapered design of the curved jaws enables precise access to tissue planes in confined spaces. The intuitive dual mode energy button is designed to improve focus on the surgical field and procedure. The Sonicision curved jaw device has an improved reusable generator that is now autoclavable and enables 1.5 times more procedural uses than the legacy device. The improved battery can be used in twice as many procedures. The redesigned charger features a user interface that provides easy-to-interpret battery charge status and battery end-of-life indications, enabling efficient battery management. The non-sterile nature of the battery also removes the need for sterilization and streamlines preparation for reuse, and provides an 88% increase in battery capacity, which may mean fewer procedural delays due to mid-case battery exchanges. The Sonicision curved jaw cordless ultrasonic dissection device. Feel the freedom.
So basically, the generator has all the haptic and visual feedbacks. This gives you the amount of shows the amount of battery left in the battery and the number of cases left in the generator as well. And the reason for single button activation is because you don't have to look to the instrument to see which mode has been activated, and you don't lose focus on your OR field. With a single button activation, you know which mode has been pressed. Now talking about the electrosurgical consumables, what we have, starting from the patient written electrodes, we have adult REM pads, we have infant REM pads, and neonatal REM pads. Why we call it REM pads? Because it's a Medtronic's trademark device. This also has the adaptive REM technology. So when it is connected to the ESU, and with the adaptive REM technology, when the generator senses what's the tissue contact percentage in the skin. So if the pad is less than 60% of contact, it automatically shuts down the power, which also results in no patient pad side burns. And when the REM pad actually senses that the impedance is more than 135 ohms, the power is automatically stopped. This is only with the adaptive REM technology what Medtronic has and works with our ESU generators. We have all the sizes available for adult, infant, and neonatal. Talking about the electrosurgical pencils, we have a 2-button electrosurgical pencil as well as a 3-button, which I talked about earlier, called Force Drivers device.
As you can see, it has 3 buttons, and with a Valilab button, you can use it with a single button. You can use both the modes of cutting, coagulation as well as dissection. We also have a slider at the side of the pencil through which in the sterile field only you can increase or decrease the power settings. So you don't have to depend on other person to increase the settings. Based on your preference, you can slide the pencils button and the power will be automatically adjusted. We also have a range of bipolar forceps and reusable bipolar forceps cables and foot pedal cables, along with a clean coat laparoscopic electrodes. This is basically a laparoscopic electrode which can be attached to the pencil itself. So there's no need of attaching it to another grab handle. With an electrical pencil only, you can attach at the top the electrodes. We have all the sizes of L hook, J hook, spatula, and we also have ball electrodes. We have needle electrodes and blade electrodes as well. And last but not the least, we have laparoscopic smoke evacuation system. As you all know, with the use of monopolar energies, there's a lot of smoke in the surgical field. And talking about the laparoscopic surgeries in the abdominal cavity, it fills up with smoke and the visibility is very less. So with this simple device, you can effectively remove all the surgical smokes with a small button. This is a consumable one. We also have a capital equipment called Rapid Vac, which can also be attached to the electrical pencil, and it effectively removes the smoke and clears the OR field for a better visibility. So thank you for the time. I would request everyone to visit the Medtronic booth over there, and you can see entire range of products starting from the Hugo robot system to energy devices, as well as the stapling innovations and suture innovations. And thank you for the time and thank you for the opportunity. Thank you so much. Sure.
Regarding this cordless ultrasonic test. Right. Do we have any arrangement for setting from 1 to 5?
Yes, sir. I get your question. So the beauty of this product is, like the LigaSure, what we have in LigaSure, there's no power settings. This also works on the principle of 3-phase algorithm. So when you grab the tissue and activate the button, suppose you're activating the minimum mode with the coagulation mode. When you grab it, it immediately understands the impedance of the tissue and it raises the temperature simultaneously. Once the optimum temperature is reached, then it starts cooling down with fusing the vessels. So there's no need of any power settings with that. It automatically senses the power settings and delivers the optimum energy to either coagulate or dissect the tissue, what you're using it. Unlike the competition, what we have, there's other power settings. This is completely automatic, and you don't have to set any kind of power limits to this to get the surgical tissue effects. Yeah, there's only 2 modes: cutting and coagulation. Yes, sir. With 7 mm of coagulation, and we have coagulation both the modes. In the minimum mode, you have 7 mm of coagulation, but in the maximum mode, the dissection mode, you also get dissection plus 5 mm of coagulation. So, any more questions? How to make up? Sir, we have there's 2 ways. The first is the audio feedback. Sir, I can't hear you. So, you want to know the size of the vessel, how to identify that? This shaft, as you can see the shaft, this is the 5 mm vessel diameter of the shaft what we have. So with the shaft only, you can compare the vessel and see if it's more than 5 mm or less than 5 mm. So this is actually I've learned from a surgeon on how to measure the vessel size and the diameter of the vessel with the help of the shaft only. This is a 5 mm of diameter. With that only, you can measure it's more than that or less than that. And accordingly, you can use the minimum mode and the maximum mode. Any more questions? Someone was talking about the weight. Sir, it is 224 grams. Yes, sir. We have all the sizes available starting from 13, 26, 39, and 48. So once you put in the laparoscopic, like in the trocar, with the center of gravity, you won't feel the weight, sir. With the Nemo inside in the center of gravity of the trocar, it automatically balances the device into that, and you won't put any kind of weight into it. And we have all the sizes available starting from 13, 26, 39, and 48. As like the LigaSure what we have, and we have all the sizes for this also. No, excluding the hand grip, just the shaft length. This is the shaft length I'm talking about. 13, 26, this is a 26 one for open cases. 13 we have for the surface visit procedures, in ENT procedures, and in talking about the GI cases like all the surface related procedures, we can use 26 and open for 39 for laparoscopic. 48 is for bariatric. Sorry, sir. Cost. Sir, basically the MRP of this device is 78,000, and it depends upon the hospital on the negotiations. MRP INR for a single instrument, hand instrument. Yes, sir. Sir, actually, we have different modes of placing this instrument. We have a outright sale where the hospital purchases the entire set. We also have a placement model where the battery, generators, and all the capital is being placed free of cost, and the hospital needs to purchase the hand instruments only. So we have both the options to get into the account. The entire, if you purchase outright, it costs somewhere around 10.5 lakhs. And yeah, including the generator, the batteries, and the hand instruments. And this other mode of placement offers what we provide to the accounts as well. So any more questions? Yeah, ma'am. Generator is 150 cases, battery is 200 cases. You also get the indication of how much cases is left in the generator through a visual feedback, and the amount of bad cases left in the battery in the generator itself. No, sir. It once you activate it once you insert and activate, it counts one. There's no it doesn't depend upon the length of the surgery. Once you activate and count, it starts counting itself 1, 2, 3, 4 like that. So if anybody's planning for a demo, you can contact the nearest Medtronic employee, and we will be arranging a demo of this instrument with the specialist accounts as well. So thank you all for the time. Thank you so much. Thank you.
Thank you. So we will be moving to a next session that we feel is very important, is stoma management. We will have some brief lectures. This will be followed by the hands-on on difficult stoma situations outside at the exhibition hall. First, we would like to invite Dr. Rashu Kureli from Coloplast for the brief discussion on the stoma management. Thank you.
Audio. Hello, everyone. I am Dr. Ashu Kurele. I serve as clinical manager at Coloplast, and over the next few minutes, I invite you to join me as we dwell into the captivating world of Coloplast Academy initiatives in this vital field. First of all, I would like to thank Dr. Deep Goyal for giving us this opportunity to uncover the transformative products and pioneering approaches that are shaping the future of stoma care. So a brief introduction about Coloplast. Coloplast is basically a multinational medical device company which is headquartered in Denmark that develops, manufactures, and markets medical device and services related to ostomy, urology, incontinence, and wound care. Coloplast goals to make life easier for people with very personal and private medical conditions. Coloplast philosophy is building intelligent designs
Basically, the products which are inspired by listening to healthcare professionals and patient needs, advanced healing technologies which meets user friendliness and award-winning designs. We also believe in deeper knowledge and guidance, for which we have dedicated educational programs to improve the global standard of care, practical guidance, and tools that help healthcare professionals efficiently. We believe in closer collaboration, long lasting and rewarding partnerships, tailored solutions sensitive to individual needs. As you all will agree to a point that living with a stoma is not easy. 91% of the people with a stoma worry about leakage, and 76 have experienced leakage over the last 6 months. 73% of the people with a stoma experience skin complications, and 12% of the people with a stoma isolate themselves because of their worries. We have various multiple stakeholders involved in the managing a patient. They might be surgeons, physicians, oncologists, psychologists, stoma care nurses, support staff, as well as the attendants and different associates. We believe that treatment goes much beyond the actual surgery, and improving clinical outcome by involving all the stakeholders at each step is the key. Now, thinking from a patient perspective, he has a lot of questions. What is life going to be like? Can I be normal or care as I was? Will I be able to work and do regular activities? Can people come to know that I have had this condition by looking at me? Will I be able to do many daily activities and many more? Generally, issue faced by patients with intimate healthcare needs influences their physical, mental, emotional, and social life. The challenges which patients face is limitation in physical activity, discomfort, and foul smell, skin complication, leakage, which leads to extreme emotional changes, emotional loneliness, loss in faith in God, fear and sadness, and inability to cope. The majority of the patient even do not seek professional help. Now, how we can help? So our goal is to partner with you all and all the stakeholders involved in the patient journey to improve the clinical outcome, for which we have an initiative and Coloplast Academy, which is a dedicated clinical arm team of doctors and trainee of Coloplast India at an arm length away from the commercial organization, dedicated to partnering with all the stakeholders in the patient journey for various initiatives to elevate clinical management and to focus on holistic health of the patient, to improve the clinical outcome and enhance the standard of care, to make their life easier for the people with intimate healthcare needs. We have various educational programs for various stakeholders involved. For surgeons, we have LeadCon, wound care days, care clinics, various RTMs. For nurses, we have ostomy days, certification programs, regular training sessions, CMEs. For patients, we have awareness camps, in-house care nurses, and patient can also contact with our support, email support, or we have a consumer care team which is trained in 9 different languages. We have a dedicated Indian website and an app for the patients. So we had a LeadCon, which is first of its kind surgeon conference, which happens in this category with all the top KOLs in attendance. It has a series of presentations by more than 120 top KOLs across the India with 23 speakers. It has scientific content covering, and this is a short video to show about the LeadCon which we had.
Hi, I'm Venki Munekrishnan, consultant colorectal surgeon at Apollo Hospitals, Chennai. I'm very happy to be part of the second LeadCon event from Coloplast. The first event in Chennai was an amazing event. The second one is even bigger. We have some of the best surgeons from around the country, the people who are involved in Stoma Care, a brilliant platform where we could exchange ideas, discuss what's going on around the world in this space.
I am Harit Chaturvedi. I am from Delhi, Max Hospital. It has been a real pleasure to be here at the LeadCon and very inspiring sessions. I think we engage with a lot of professionals, so much happening in the world of science and so much happening in our clinical practice. I think these platforms are crucial. They're very important.
First of all, I thank the organizing committee of Holoplast Academy team. It is a wonderful scientific conference. We have a lot of faculties, nationwide.
Yeah, I am Dr. Jagannath Dixit. I am a practicing robotic colorectal surgeon at HCG Bangalore. And in the LeadCon 2023 is one of the excellent, eminent faculties we had.
Holoplast Academy and the organizers. And I'm sure that as we move forward, this event takes a life of its own. And I hope we keep raising the bar with every year. Thank you. And I won't hold you back any further. Have a lovely evening. And
so along with this, we also have care clinic concept. We have 50 plus care nurses on Coloplast payroll, which are always there for the patient's help. We have a dedicated Indian website. We have My Ostomy app. We have consumer care team, which is trained in 9 different languages to communicate and resolve the queries of the patient. We have a chatbot facility. We have social media support, and we have more than 120 people on the field. We also had a program, a conference in wound care and skin management over a cross-specialty conference, which is generally attended by plastic surgeons, general vascular surgeons, ortho surgeons, and intensivists. For ostomy days, we have a dedicated program for nurses, which was attended by more than 100 nurses from pan-India. An agenda basically designed towards a collaboration in adapting a proactive and consistent approach towards the holistic patient care. And it covered the entire patient journey from pre-surgical counseling to stoma marking, innovations in stoma management, application technique, hands-on practices, discharge counseling, and stoma complications. Coloplast Academy, we look forward to working together to improve the clinical outcome. We don't want our patient to just survive, we want them to flourish. For this, we believe in partnering with the key hospitals, for which we have an initiative known as care clinics, which is basically raising the standard of care of the patient in stoma management. And the objective of care clinic is basically partnering with the key hospitals across India, developing a clinical conviction amongst nurses and patients around the stoma management, raising the standard of care by creating awareness and establishing standard guidelines and protocols for ostomy management, acting as a nodal and ideal center to establish a stoma care as a concept in clinical practice, and working together as a clinical case studies and research to improve patient care. We also believe in hand-holding of the patient from the initial journey, be it pre-surgical counseling or counseling during the surgery or in hospital, in ICU wards, discharge, and even at home. We have a very innovative and most latest product, which is Sensora Mio, which has, so this is just small video showing the various features. Just some. So Sensora Mio is the latest bag which we have. It is a circular filter and it is all textile material which is neutral gray in color. So this filter is a circular, so it will prevent ballooning, and it is proven that it reduces ballooning up to 61%. It also has a new click coupling with wave-shaped lock ring, which provides extra security and extra reassurance to the patient. So these are the 4 features of the Sensora Mio, which is new elastic adhesive for a secure fit. And it has a textile material, which is a neutral gray in color. So the motive of this color is basically providing discretion to the patient, and unique full circle filter for reduction in ballooning, new kick coupling with wave shaped lock ring. And basically it is designed to go unnoticed. It is smooth on skin, it is smooth under the clothes, and it's almost invisible, and it is also water repellent. This unique filter, as I have already talked about, has 4 different layers, which basically does what it does is basically up to 61% of the ballooning is reduced with this product. This new coupling system basically it has new wave shaped lock ring that provides a great reassurance by applying the bag to the base plate. The wave shape is very interesting as it ensures that the user gets the same experience every time to apply the bag to the base plate, because any tolerance in the coupling systems are generally absorbed by this wave shape. It also has a unique body fit technology that is magic behind the Sensora Mio products. It is twice as stretchable as the traditional appliance which are available in the market. And even the deep convex base plate which is available is twice as flexible as the traditional light convex appliance. Now, I would like to thank you all for everyone for your attention and participation during the presentation. And we'll be continuing this with the workshop for the products. Thank you.
Thank you so much. Now we will request Hollister Gift to present your presentation here. Thank you.
चार्जर लगाने की जगह है चार्जर लग जाएगा ना लग जाएगा किस टाइम
Okay. Chance to क्या चार्जर नहीं है
चार्ज हो रहा है
presentation
इसमें है ना
हो गया सर पेंटेज में देख लीजिए मैं अपने लैपटॉप पर डाल पीसी में
इसमें नहीं आ रहा
नहीं आ रहा वो कनेक्ट नहीं हो रहा आपका हमारा लैपटॉप है
So we are left with 4 candidates: Azhar, Abhinav, Anvesh, Anoop, and Sanjay. So they will participate in the final round of the future competition. After that, Dr. Anvesh, Dr. Abhinav, Dr. Sanjay, we are going to final round.
I start. So good afternoon, everyone. My name is Lalit Sharma. I represent S3 Sales Hollister. I have my colleagues with me also. Just to tell about the company in a very brief, Hollister is 100 years old company based at USA. And in India, it is 30 years old. Through S3 Sales International Private Limited, it was launched by our managing director, Mr. S.K. Jhingan. Hollister is known worldwide to provide the best skin barriers in the world. So with that, just a brief introduction about our company. First of all, I would like to thank the BLK Max team for providing us this opportunity to present. And they decided to talk about few areas, few complications on stoma care. So let us come back to the stoma. What is an ideal stoma? An ideal stoma is pinkish red and moist. It should be 1 inch or 1.5 inch sticking out of the skin surface. That is the ideal stoma, as we all know. Now, other thing is that stoma sighting, which is very, very important. Stoma sighting is a decision made by the patient and ET about the most suitable place for their stoma. Its positioning allows the patient to manage stoma independently post-operatively. Stoma sighting is a very important component because at each stage, explanation to the patient is necessary as regards need for accurate placement of the stoma and reason for selection of purported site in order to gain cooperation and confidence of the patient. Now, 1 or 2 complications we'll talk about. That is, one is the prolapse stoma, when stoma comes out in a larger size. Prolapse stoma, it occurs when intestine protrudes through the stomal opening in the skin to a greater extent than anticipated. This is known as abnormal protrusion of the stoma. The amount of protruding bowel can vary from 2 to 3 centimeters to 10 centimeters. It becomes difficult to pouch a prolapsed stoma. Prolapsed stoma more likely to affect people who have weak supporting muscle, belly muscles, and this is more common in babies. The patients who are overweight, obese, and have a flabby tummy, and straining the abdominal muscle by way of pressure through lifting, coughing, sneezing, and because of the constipation. Pouching system which has to be used for in case of prolapsed stoma, if stoma has also increased in width and length, needs to increase the size, maybe of the cutting area and size of the length of the pouch to accommodate the prolapsed stoma. Reduce the stoma, of course, when the stoma is prolapsed, it is difficult to pouch the patient. So reduction of stoma is important, and after that, the application of the stoma bag can be made. The skin barrier should be hugging the stoma and not showing the excess skin of the peristomal area. Pouching system should not be convex or a rigid flange, because that may increase the size of the prolapsed stoma. generally a flexible system is recommended. Skin excoriation is the most common problems in the stoma cases. And the skin excoriation is exposure of colostomy, ileostomy, output to the peristomal skin result in skin excoriation. This is because the colostomy and ileostomy output is rich in enzymes. Skin irritation is usually caused by leakage from ostomy pouch and the output from stoma getting underneath the skin barrier and onto the skin. And that is how it is. Excoriation is taking place. In case of excoriation, the stoma powder or ADAP powder that we provide, it is actually used before the application of a skin barrier. So whenever there is an excoriation, there is a we need to sprinkle the powder which makes it dry on the affected area. In this case, when we use powder, we say that less is best. So wherever we have the excoriation, we just have to sprinkle. Sometimes it is seen that we spread the powder all over the area. That is a waste of powder. And then after waiting for a few minutes, 2 minutes, 2-3 minutes, we remove the excess powder. So wherever is the excoriation, the stoma, the stoma powder will settle down and it will absorb the moisture. So that area will become dry. Powder, stoma powder is nothing but hydrocolloid. And hydrocolloid, we are applying hydrocolloid. Skin barrier is also hydrocolloid. So the forms are different, but the forms are different with different roles. So what we are trying to do is by using ADAP powder, we are trying to absorb the moisture and making the area dry so that the skin barrier, which is a flange, can be applied safely on the peristomal area. So next we have is the retraction. There is another problem. Retraction when the stoma is retracted because of the post-operative complications if the intestine is pulled below the surface of the skin by more than 5 mm. Stoma retraction is often caused by tension placed on the mucocutaneous junction. We have retracted stomas, we have flush stomas. In this case, the role of convexity, the convex skin barriers, they come into existence. Because if we have flat skin barriers, then the exudates will reach to the peristomal area, therefore causing the excoriation. But the convex skin barrier will push the area around the stoma, which is peristomal area, and stoma will protrude outside so that the exudates, they are falling into the pouch by not falling on the peristomal area. And that is how convexity becomes very, very important in those cases when the stoma and is retracted and flush stomas. Suppose there is a fold on the peristomal area, so it will make the area flat so that the convex skin barrier can stick on it, and we are avoiding the spread of exudates which contains enzyme on the peristomal area, and the exudates are falling into the pouch. So convex skin barriers promote a good fit between the ostomy pouching system and the peristomal skin, where the flat barriers would be unsuccessful. This is achieved as a convexity barrier pouch pushes the, as I said, surrounding the skin and the exudate, they go directly into the pouch. These are the convex skin barriers. We have convex rings. Polyester also provides convex barrier rings. These barrier rings are alcohol free. So we can stretch these to the size of the stoma and use as a substitute of the stoma paste, and we can mold it and we can cut it in any size and fill the contours so that the area becomes a flat one, even area, so that a skin barrier can stick on it nicely. Even polyester provides the convex barrier rings. So these can also be used. These can be applied on the flat surface, and this can give a convexity to the pouch whenever it is required. In case of, I said, retracted stoma or flat stoma. And of course, the convex skin barriers we use on the wrinkled skin so that convexity can make it a smooth one, and there's a flat surface so that a skin barrier could be applied nicely there without any problem. So if we talk about the convexity, convex products, they have their own importance and role in case of ostomy. So this is all about my conversation. And once again, I would like to thank Dr. Deep Goyal and his team for providing this opportunity. We have a stall there. Please come. And for the hands-on practice we have, anybody who would like to do it, you are welcome. Thank you so much for the time given.
We also have among us Prashansa. Prashansa is one of the patients who's undergone surgery and she has a permanent stoma. We would like her to just tell us very briefly that what all difficulties she encountered after the surgery, not in terms of adjusting with the stoma, but in terms of the products which were available and how she innovated and what she has learned.
Thank you for inviting me, and it's quite embarrassing and also. एक्चुअली स्टोमा से मेरा इंट्रोडक्शन आफ्टर द ऑपरेशन ही हुआ था. कुछ इमरजेंसी में मेरा ऑपरेशन करना पड़ा था एंड डॉक्टर दीप गोयल ने ही मेरा ऑपरेशन किया था एंड दैट इज वेरी, आई थिंक आफ्टर द स्टोमा आई एम वेरी कंफर्टेबल. यू कैन सी, you cannot see anything in my, there is nothing, there is, आप कोई बोल ही नहीं सकता कि आई एम हैविंग समथिंग. मेरे फादर का कॉन्स्टिपेशन रहता है, वो 10 घंटे मतलब बहुत देर तक रात में कभी कुछ फाइबर खाएंगे कभी कुछ खाएंगे. मुझे सुबह अगर जाना होता है तो हार्डली 5 मिनट्स और 2 मिनट्स जाता है और आई एम ऑल क्लियर, कोई इशू नहीं है. और हाँ, थोड़ा सा प्रोडक्ट्स का यहाँ पे इंडिया मैं अभी वही बोल रही थी कि मेरा खर्चा 4 से 5 हज़ार रुपए का पर मंथ का खर्चा है मेरा सिर्फ इस बैग का. एंड आई एम ग्लैड कि आई डोंट स्मोक और ड्रिंक और ये सब कुछ, और कोई खर्चा नहीं है. अपनी शॉपिंग है, अपना काम है, और ये एक इसका जो एक एक्स्ट्रा जो खर्चा आप कह लो लोगों के जैसे स्मोकिंग और घूमने फिरने के वो होते हैं, ये है. आई डिड स्कूबा डाइविंग, सब कुछ मैंने मतलब आई ट्राइड एवरीथिंग जो भी आप एक नॉर्मल बंदा करता है. और मैं ऐसे कुछ छुपा के भी नहीं करती क्योंकि लोग जैसे कि अब मेरे फादर की अभी लास्ट ईयर एरोटिक वॉल्व का ऑपरेशन हुआ तो उनके यहाँ पे कुछ वो डाला गया वॉल्व स्कॉट्स में करवाया था. तो दैट इज इन इनसाइड और ये कह लो कि आउटसाइड है. एंड मेरा रिवर्सल भी हो सकता था लेकिन आई चूज टू बी लाइक दिस क्योंकि अल्सरेटिव कोलाइटिस क्या होता है कि आपके और भी बॉडी ऑर्गन्स को वो यही है कि अभी मैं खड़े होके गोलगप्पे भी खा सकती हूँ कहीं पे एंड आफ्टर दैट कि मैं एक रिस्ट्रिक्टेड डाइट में रहना पड़ेगा मुझे अगर मैं रिवर्सल कराती हूँ. प्रोडक्ट चुनने में हाँ बहुत थोड़ी सी इश्यूज आते हैं क्योंकि यहाँ पे जो ये लोग बताया है जो भी है, ऐसा कुछ नहीं है, सिंपल सी बात है। तो यू हैव टू मैनेज योर ओन, जैसे कहते हैं ना, आपको जीन्स, आपको हाई वेस्ट किसी को पसंद है, किसी को लो वेस्ट पसंद है, तो इट डिपेंड्स ऑन यू, क्या विच ब्रांड यू आर कंफर्टेबल। बैरियर रिंग हॉलिस्टर का आई एम यूजिंग इट, दैट इज वेरी नाइस, जो कि हाँ। और कोलोप्लास्ट का जो म्यू आया है दैट इज ऑल्सो वेरी गुड, बहुत फ्लेक्सिबल है। लेकिन जो कोलोप्लास्ट ने क्लेम करा है कि हम ये करते हैं, हम वो करते हैं, ऐसा कुछ नहीं है। अभी रिसेंटली बिफोर कोरोना आई मेट दी ओम बिरला और हर्षवर्धन, तो इसके 5% जो जीएसटी, उसका एक पार्ट मैं भी रही हूँ, बहुत चैरिटी कर रही। लेकिन आफ्टर माई मॉम, आई लॉस्ट माई मॉम तो 2 साल पहले, तो उसके बाद से मैंने सब कुछ बंद कर दिया है। मैंने कहा यार अब चैरिटी कम्स फ्रॉम दी होम, तो अब पहले अपने को ही जी लो, उसके बाद दुनिया का कल्याण हो जाएगा। तो आई रियली रेस्पेक्ट दीप गोयल। तो ही इनवाइटेड मी एक्चुअली कि भाई तुझे आना है, तो मैंने कहा ठीक है चलो, मैं टाइम निकाल के, मैंने कुछ क्वेश्चंस निकाला। हाँ, म्यू जो आया है दैट इज वेरी कन्वीनियंट, पर इसका जो बैरियर रिंग जो आया है दैट इज, उसमें मुझे लीकेज के बहुत इशू आए थे। तो अभी मैंने कोलोप्लास्ट का जो यहाँ पे एक्चुअली इंडिया में सेंटर बना रखा है, तो दैट इज वेरी कन्वीनियंट। तो उन्होंने पूरा बॉक्स चेंज करके मुझे दिया है फ्री ऑफ कॉस्ट, क्योंकि मेरे काफ़ी बैग्स लीकेज वगैरह का इशू बीच में आ गया था। तो यू हैव टू, मतलब आपको खुद ही टैकल करना है कि आपको क्या है। यहाँ पे सिर्फ एक ही नर्स है इंडिया में, नीता सरगंगा नाम में, जो बैठती है। अभी मेरे खूब चक्कर लगे थे, आई डोंट टेल यू कि मैं क्या करूं, मुझे बड़ा परेशानी हो गई थी। तो नीता ही एक है जो कि जिसके पास थोड़े बहुत सॉल्यूशंस हैं, अदरवाइज कुछ नहीं है यहाँ। आप या फिर बॉम्बे में है ऑस्टमी नर्सेज वगैरह, मैंने ऐसा कुछ सुना नहीं कि यहाँ पे कोई एक्सपीरियंस्ड कोई बंदा हो। और ये है कि आप पेशेंट टू पेशेंट आप देख सकते हो। अब बाहर तो बहुत सारी कंपनीज है, सॉल्ट्स है, बहुत अलग अलग कंपनीज हैं, तो वेराइटी है, वहाँ इंश्योरेंस भी है। यहाँ ऐसा कोई फैसिलिटी नहीं है। इंश्योरेंस वाले इंश्योरेंस इसलिए नहीं करते हैं क्योंकि अल्सरेटिव कोलाइटिस जो है वो उनका मानना है, डॉक्टर तो क्लियर कर देगा मेरा कि आप इंश्योरेंस ले लो, लेकिन आप लोगों की जो कंपनी में, जो इंश्योरेंस कंपनी में जो गैस्ट्रोएंटरोलॉजिस्ट बैठे हुए हैं, वो उनका कहना है कि ये जो अल्सरेटिव कोलाइटिस है वो आंखों से लेके सारे बॉडी पार्ट्स को खराब करता है, तो वो लोग लेके भी फायदा नहीं है। और कुछ, इफ यू वांट टू आस्क मी।
idea was asking you to speak was that in our country still there is a lack of social support for people who have stoma. Also, trained professionals are very few in very few institutions. Like in our hospital, we have Shiji and Ganga who are with us since now 10 years, and they're very experienced, dedicated. But I think it is our duty as surgeons to train staff and to also, sort of make sure that our patients get psychological support from patients itself. There are various societies which are available now, various groups which are available in India, which are doing, like Prashansa is part of such group. She, whenever we call her up and we refer a patient, she really counsels those patients psychologically. So I think it is important. It's a part of an ecosystem where, as a surgeon, we should encourage emotional support for our patients as well as technical support from the point of view of products. So that was the whole idea of just asking her to come and speak. Thank you, Prashansa. Amir, we break for lunch now? We break for lunch now, and after lunch the stalls are open for hands-on training on robots or suturing, whatever you guys want to try. Yeah, a stoma workshop, and then we all will be available if you have any questions regarding anything. There are